But before we start today, I would like to show some questions on inflammation because I know we did not do much questions on that inflammation. So I just have 2 questions here, and maybe some other time I'm going to post other ones on the page. So this is the first one, which is a 38-year-old man comes to the physician because of fever, malaise, cough, shortness of breath for 2 months. He has had 4 kg weight loss during the same time. He works at a flour mill and does not smoke cigarettes. The temperature is 38.1. Pulse oximetry shows a value of 95%. Diffuse fine crackles ahead over both lung fields. Chest X-ray shows patchy reticulonodular infiltrate in the mid and apical lungs fields bilaterally. A photomicrograph of the lung biopsy specimen is shown. Which of the following cytokines have the greatest involvement in the pathogenesis of this lesion indicated by the arrow? So I'm going to show us the picture so we can have an idea of what is happening. Okay. Can we see the picture?
Yes.
So what do you think is happening here?
Granuloma formation.
Excellent. So this is a granuloma. So back to the question. So which of the following cytokines have the greatest involvement in the pathogenesis of this granuloma? So which option is consistent with that?
B.
B for boy.
B.
Gamma.
For boy.
That's good. That's good. That was fast. That was fast. A 38-year-old man comes to the physician because of a 2-year history of cough and progressive worsening breathlessness. He has smoked 1 pack of cigarette daily for the past 10 years. So he's a chronic smoker. Physical examination shows contraction of the anterior scalene and sternocleidomastoid muscles during inspiration. A chest X-ray of the chest shows flattening of the diaphragm and increased radiolucency in the lower lung fields. Further analysis shows increased activity of isoform of elastase, which is normally inhibited by alpha-1 antitrypsin. The cells that produce this isoform of elastase were most likely stimulated to enter the site of inflammation by which of the following substance? So,
How do we number it? A, B, C, D, E. Leukotriene 4.
okay, so Dr. Nancy, before we get to the answer, what do you think is going on here? What's your diagnosis?
Emphysema.
Alpha-1.
This is emphysema. So what form of emphysema is it going to cause? Is it going to be panicinal or centrilobular or which one?
Panicinal.
Panicinal. So now, what cells normally release alpha-1 elastase rather? What cells normally release
Neutrophils.
Neutrophils.
Okay. And also.
Exactly.
So
So what our answer going to be?
Leukotriene B4.
With the chorus answer, so I want to assume that all of us understand what is happening here. So they are just saying that there's an increased activity of the elastase, and that elastase is an enzyme that is produced by the neutrophils. And normally, the protein that keeps the activity of the elastase in check is the alpha-1 antitrypsin. So anybody that has a problem with alpha-1 antitrypsin cannot keep their elastase in check. So that means that elastase will just be there destroying all the elastic fibers, such as the ones in the lungs, leading to, alveolar issues like COPD. So the cells that produce the elastase were most likely stimulated to enter the site of inflammation by following substance. So they are just asking us what is a chemoattractant for the neutrophils. And just like one doctor gave us the acronym, I can't remember the acronym something something
Chill,
coming.
neutrophil is coming.
Chill.
Neutrophil is coming.
Chill. Neutrophil
Exactly.
is coming.
So just check neutrophil, something something is coming, you know, and you pick the right one. So I think this one should be 5A if it's going to be correct, not 4A, right?
Yes.
Yes.
Okay.
Mhm.
So I'm sure that there's no question on acute or chronic inflammation that we cannot solve. I'm serious. Forget the fact that I'm showing you two questions. If you really follow the lecture we did and you have a good understanding, there's no way you will not be able to solve any questions on inflammation. It's just going to be very straightforward and easy for you. So moving on to scar formation. And we said that scar formation can be a consequence of acute and chronic inflammation, but most of the time it follows chronic injury, chronic inflammation. And it typically occurs when you have an injury or an insult to a cell in which cell regeneration is not enough to replace that damage. So when cell regeneration is not enough to replace the damage, scar formation ensues. And sometimes you can have a very large injury that you can not only regenerate that cell to fill in the defect, you need to deposit some fibrous tissue to form scar. So that's right about scar formation, and we have to remember that um, the basis for forming the scar is just you laying down collagen. That is it. You lay down collagen to fill up the scar. And when we're talking about wound injury, wound healing rather, I mentioned some phases. We talked about the inflammatory, the hemostasis, the inflammatory, the proliferative, and the remodeling, if you remember. And during the proliferative, we talked about deposition of collagen by the fibroblast, right? So what type of collagen is being deposited there? Anybody remembers?
Right? Three.
Type 3.
Collagen,
Type 3 collagen.
exactly, collagen type 3. Then during the remodeling phase, it gets degraded by what enzyme?
Metalloprotein.
Collagenase.
Metalloproteinase,
Collagenate.
which is
Metalloproteinase.
exactly which collagenase is an example, and it gets converted to collagen type 1. And I said it that when it gets changed to collagen type 1, the tensile strength of that wound increases. So, and this brings about the statement of 70 to 80% of the tensile strength is regained at 3 months when you have collagen type 3 being converted to collagen type 1. But in some situation, you can have an abnormality in which that scar formation becomes too excessive more than what is needed. And that brings us to the concept of the hypertrophic and the keloid scars. The keloid scars and the hypertrophy. So both of them, they are associated with aberrant scar formation. And there's a particular growth factor that you must always watch out for in your exam that is responsible for this abnormal scarring, and that is transforming growth factor beta. Please don't pick fibroblast growth factor. Don't be deceived. The the cytokine that mediates the excessive scarring is always transforming growth factor beta. Please pay attention to that. So what is the difference between hypertrophic scar and keloidal scar? You can easily pick the difference just looking at them clinically. So the hypertrophic scar, in terms of the collagen that it consists of, is just type 3. So we can say that it's an immature form, of the scar, collagen type 3. While the keloidal scar contains both collagen type 1 and collagen type 3. So how is the organization of the collagen in hypertrophic scar? It is usually parallel to the wound, to the direction of the injury. So you just see it parallel deposition of the collagen, and it makes it very fine. Why that of keloidal scar is irregular? We can see this irregular, picture here. So what about the extent of the scar? The extent of the scar in hypertrophic scar is usually confined to the site of the injury, the borders of the wound. While that of keloidal extends beyond the borders, it goes out of the site of the injury. And I want to also inform us that keloidal scar is usually very, very frequent in terms of recurrence. It can subside and it can come back again. Even if you cut, you treat it, it can come back again. That's that about keloidal scar. But hypertrophic scar does not typically recur commonly as keloidal scar. There's usually a genetic predisposition to keloidal scar because it's very, very common in dark people that have a dark skin. why you don't have any genetic predisposition in hypertrophic scar. So we should not forget that. And we typically have some sites that have an increased risk of developing keloidal scar, and that talks about the upper body. So the hair lobes, you can see that this is very close to the hair lobes, the face, generally, the face, the chest, the chest, the face, the upper extremities. Those are the areas that are very commonly associated with keloidal scar. Okay. So moving on to neoplasia. So we're almost rounding up pathology, and neoplasia is, I think, the last, then followed by aging. So neoplasia is very simple. Questions on neoplasia is inevitable. You are going to see questions on neoplasia. And what is neoplasia all about? This is just uncontrolled monoclonal proliferation of cells. When you have cells reproducing or proliferating in an uncontrolled manner, you say that this is neoplasia. And we can have two types, the benign and the malignant. So the benign one are the one that the proliferation is kind of controlled. They don't invade neighboring structures. But for malignant, it gets disseminated to distant sites, which we are going to talk about shortly. So what are the two components of a neoplastic mass? The first is the parenchyma. So what is the parenchyma? Parenchyma is just majorly the cells of the tumor. So we are talking about lung cancer now. So the lung cells themselves, that's the parenchyma. And they usually have a supporting stroma to help them grow, to nourish them, to also help them disseminate. For example, the blood vessels and the connective tissue, the extracellular matrix scaffold. That's what we mean by the connective tissue. And the blood cells, the lymphatics, the arteries, the veins that surrounds them, those are the supporting stroma. Now, so this is more like a progression of neoplasia, starting from normalcy to pathology. So a normal cell should appear like this. This is the epithelial lining, all the cells resting on the basement membrane, and they are all nourished by the blood vessels as well as the lymphatics. This is how a normal cell should appear. But you can have some transformation, maybe due to stress. A cell might be subjected to some hyperplastic transformation, maybe due to increased hormonal stimulation, or it can be subjected to a metaplastic transformation. Just like we said, when you have a reprogramming of the stem cells, maybe due to the form of some irritation or stress of any form. Now, from that metaplasia, from that hyperplasia, they can progress to dysplasia, just like we talked about. And anybody wants to remind us the acronym for dysplasia? Anybody remembers? So we talked about pica, in which P is starting from for the pleomorphism, in which you have an abnormality in the uniformity of the cell size and the shape. So you have different shapes, different size. Now we talked about height, so which is what's the height standing for? Anybody remembers? Increase what?
Increase nuclear cytoplasmic ratio.
Exactly. So you have an increased nuclear cytoplasmic ratio, which is very, very important. A very important feature you have to look out for. Then what's the C standing for? Anybody remembers? The C.
Clumps, chromatin.
Chromatin clumping. Then the A stands for abnormal mitotic figures. So don't forget about that for dysplasia. And I told us that it occurs in grades. You have the mild, moderate, and severe, depending on the extent of the dysplasia, starting from up to down. So, and we talked about carcinoma inside too. So we said it is an irreversible form of severe dysplasia in which you have the dysplastic changes extending to the basal cells. So once it gets to the basal cells, that is carcinoma in situ. But it has not breached the what? The basement membrane. Because once it breaches the basement membrane, it becomes what? Invasive carcinoma. It becomes invasive carcinoma. And what do you need to breach the basement membrane? Number one, there should be loss of cell-to-cell contact. So the cells-to-cell attachment is lost. And don't forget, when we're doing dermatology, I mentioned the function of ecadherin. Ecadherin is very, very important as far as neoplasia is concerned. You cannot, talk about neoplasia and you don't know anything about ecadherin. That is impossible. E-cadherin is one of those addition molecules that helps to hold the cell together. And when they are held together, because of contact inhibition, they cannot spread. So they are confined to that site. But when there's a mutation of E-cadherin, it means that the cell-to-cell attachment is lost and they can easily disseminate. And when that happens, there's release of a particular enzyme by the cells that you call metalloproteinase. An example of that is collagenase and hydroxylase. What is a cofactor that is required by metalloproteinase? Anybody remembers?
Zinc.
Zinc. So once they put in their zinc, they activate the collagenase and the hydroxylase and they start lysing the basement membrane. And from there, they can now extravasate out of the basement membrane into the surrounding tissue. But they are still confined to the surrounding tissue. They have not entered the blood vessel. By the time they enter the blood vessel and they travel to other sites, they have metastasized. So that is the progression. So hope it's clear to us. I think we can move. Okay, so moving on to tumor nomenclature. The two common ones include carcinoma and sarcoma. So carcinoma and sarcoma. So carcinoma just means that the tumor is from the epithelium, while sarcoma means that the tumor is from the mesenchyme. Very simple. Now, that's like a basis for classification. Then you can also classify them according to their nature. Is it benign or malignant? So benign tumors are usually well differentiated and well demarcated. Don't forget, you cannot go for your exam and you don't know this. It is as basic, very, very basic and important at the same time. Benign tumors are well differentiated and well demarcated. When we say that a tumor is well differentiated, what we mean is that that tumor looks very closely to the parental cell. So that means that if a tumor is occurring from a lung, that lung tumor looks like cells that come from the lung. That's the meaning of a well-differentiated tumor. And that talks about the grade of that tumor, which we are going to talk about shortly. Benign tumors also have low mitotic activity. They are not actively proliferating. They don't metastasize, and there is no necrosis. But all these things happen in opposite for malignant tumors. Malignant tumors show poor differentiation. That is, they are anaplastic. So if they say that a cell is anaplastic, it means that it shows poor differentiation and it does not look exactly like the parent cell. It looks differently from the parent cells. Their growth is erratic. You cannot predict it. They are growing haphazardly. They can locally invade surrounding tissue due to what? Release of metalloproteinases, like we have talked about. They can metastasize afterwards, disseminating into the blood vessels and the lymphatics, and there is a reduction in apoptosis, depending on the pathophysiology of that malignancy. They don't die. There's reduced apoptosis. Now, having said that, we also need to talk about some malformations that are not benign tumors and they are not malignant tumor. You have to pay attention to this. So these are the marks. If step 1 is graded, these are the questions that you can palm for you to escalate your score into stuff like 250s and 260s, because everybody knows benign tumor, everybody know malignant tumor, but do you know amatomas? Do you know choristoma? So these malformations are non-neoplastic malformations. And what is amatoma all about? I just want us to picture amatoma as a disorganized overgrowth of tissues in their normal sites. For example, in the lungs, maybe the lungs are supposed to have smooth muscle, cartilage, blood vessels, and they should be well arranged in a particular form. But sometimes you can have a growth in the lungs in which the cellular constituent of the lungs are not arranged in a well distributed pattern. It's just, you are just mixing smooth muscle with cartilage with the blood vessel, in a disorganized area. That is amatoma. So a very good example of amatoma is our Suit-Jeghers polyps. Anybody wants to give me the findings that quickly raise your suspicion for Suit-Jeghers? Anybody? I don't need us to go to town. Just the clinchers, Suit-Jeghers. Anybody knows?
You have mucosa.
The
Purple.
apples on the lips.
On the lips.
Marcus of hyperpigmented
Hyperpigmented.
Hyperpigmented.
for the lips. Then there's a risk factor for numerous polyps, right? Numerous polyps
Intestinal
in the intestine. There's also risk factor for multiple GI cancers. So that's Sujegas. Very important. It is an amatomatous growth. Very important. So it is a growth of tissues in the usual location they should be, which is in the GIT, but their growth is disorganized in terms of the mixture of the constituents. Why cholesteoma means that you have a normal tissue in a foreign location. So what they are saying is that, for example, somebody having a gastric tissue in the ileum, that doesn't make any sense. Or somebody having a pancreatic tissue in the ileum, and that happens in Merkel diverticulum. Do we agree with me? In Merkel diverticulum, there can be pancreatic tissue in the ileum. Anybody agrees with me? True or false?
Yes.
Yes.
True.
True.
So you can have pancreatic tissue there, you can have gastric tissue there. So,
That's true.
but most of the time it's usually gastric tissue, but it can be mixed. Rules of two, you know. So that's a cholesteoma because you're having gastric tissue in the ileum. That is an abnormality, cholesteoma, you know. So moving on to the nomenclature, the epithelial tumors, carcinoma, two types. For the benign, you can have adenoma, you know, or papilloma. So the difference between papilloma and adenoma is just that papilloma have papillary-like projections. That is it. So finger-like projections. So what is the malignant form of epithelial tumor called? Adenocarcinoma and papillary carcinoma. We are familiar with all these things. For the mesenchyme, we move to the blood cells. The blood cells. What is a benign tumor of a blood cell called? Nothing. There's nothing like a benign tumor with blood cells, you know, but you can have the malignant form, which is leukemia and lymphoma. What about the blood vessels? Benign form is called hemangioma. You just add sarcoma to the ending. Angiosarcoma. So it's not hemangiosarcoma, but angiosarcoma. And a very common angiosarcoma we have talked about in dermatology. Anybody wants to remember? Angiosarcoma of what? Dermatology. Huh?
Linked to breast cancer.
Adenoma.
Yes,
And
of course.
Andrews.
Yes. Good. But which site did they normally occur? We said it. Where?
After mastectomy.
Okay, after mastectomy in the breast, okay. Yes, but what is the commonest site that we talked about?
Around the upper limb.
Yes, so that's like the bread. It's in the head and neck. I showed us the picture of a man with, like, if you remember, an injury on the head like this. Angiosarcoma of the head and neck due to radiation exposure. So angiosarcoma commonly occurs in the head and neck. Don't forget that. And we talk about the Stewart-Trevett sign, you know, which is a chronic lymphadenopathy, or what's the word now? Like stasis of lymph flow, you know, due to lymphatic obstruction or lymphatic removal. And we have lymphatic stasis causing irritation of those lymphatic vessels there, leading to angiosarcoma of the breast or the chest. So don't forget about angiosarcoma. And we also talked about angiosarcoma of the liver, very high yield angiosarcoma of the liver. You need to know the risk factors. So moving on to smooth muscles, the benign one is leiomyoma. Leiomyoma fibroid, for example. That is smooth muscle of the endometrium, of the myometrium. Then the malignant one is leiomyosarcoma. Just once you are saying sarcoma at the end of something, or carcinoma at the end of something, you know that that's malignant. So for the striated muscle, like the skeletal muscle now, you call that rhabdomyoma. Then for the malignant form, we call that rhabdomyosarcoma. Anybody knows a neurology condition that predisposed to formation of cardiac rhabdomyoma? Anybody? It's simple. I know we know it. So anybody
Tuberous
knows?
sclerosis.
Tuberous sclerosis. That was fast. Fast. So benign form of connective tissue, fibroma. The malignant form, fibrosarcoma. For the bone, osteoma. You know, osteomas. Anybody remembers any neurologic condition that predisposed to numerous facial osteomas? So they have osteomas. They have supranumerary teeth. Their teeth is clouded together. Does it ring any bell? Numerous polyps.
Yes.
Polyps.
The cardinal polyps.
So it's in GIT. So it's in GIT. Numerous polyps.
The cardinal.
Yeah.
That's the
Cardinal syndrome.
cardinal polyps.
Cardinal
Yes.
syndrome. Osteomas. Watch out for that. They just tell you mandibular osteomas. You know, supernumerary teeth. You know, and all those things. So watch out for Gardner syndrome. Then osteosarcoma. Osteosarcoma, very high yield. Fat, lipoma, liposarcoma, and of course the nevus and the melanoma. Hope we remember the types of nevus. Hope we remember.
Yes.
What are the types?
Junctional.
Junctional,
Compound,
Intradermal.
and intradermal.
And we know the differences. And we know the differences between them. Okay. No answer. Ah.
Yeah.
Eh? So the one at the junction, the one at the
Junction
junction.
is between the dermis and the epidermis.
Yes.
Yeah. So what about the compound?
Compound is already extending to the dermis.
But you still have some component in the epidermis too.
Epidermis, yes.
Yes.
Then what about the intradermal? Strictly.
It's inside the
Everywhere.
dermis.
Yeah.
Yes.
So that's that. Then moving on to the tumor grade and stage. So what is the basis for grading? What is the basis for staging? Now I want to put it out here that the one of more grave prognostic significance is the stage. What I mean is that if you have a tumor that has a low grade but a high stage, that is more dangerous than a tumor with high grade and low stage. The higher the stage, the badder the tumor. So what is the basis for grading a tumor? You look at the degree of differentiation. That is, how well does it resemble the tissue of origin? So, and also, what is the degree of mitotic activity in this tumor? So, a tumor with a high mitotic activity, a tumor that does not resemble the tissue where it's coming from, is a high-grade tumor. While a low-grade tumor will resemble, the parent cells, and they will have low mitotic activity. So that's how you grade tumors. So low grade, well differentiated, they look like where they are coming from, and they have low mitotic activity. But the high grade, they are poorly differentiated, or they can even be undifferentiated at all, which you call that an aplastic tumor. So high grade correlates with higher aggressiveness. Yeah. So if you look at this picture now, this one still looks like this surrounding cell, but this one is looking different. You can see that the nucleus is even more, the nucleus cytoplasmic ratio is higher than all these ones, and they have different shape, different color, and all these things. So that talks about this being a high grade compared to this. So moving on to staging. So what I just want us to take home for staging is just the TNM. That's the basis that we usually use. TNM staging for breast cancer and other cancers. So the T stands for the tumor size. The N stands for the lymph node status. Then the M stands for metastasis. Now, in order of relevance, the M is the most important, followed by the nodal status, followed by the T, which is the tumor size. A tumor that has already metastasized, you don't even need to be doing other T and M. It's already a high stage. So that's why M is very important. In fact, you just ask the question, has this tumor metastasized or not? Once it has metastasized, you put it in a very high stage. Then if it has not metastasized, you can look at the nodal status. Okay, what nodes have been involved? Then before you can now consider the size of the tumor. So they combine all these three things to grade into the stage. And don't forget, stage has a what? More prognostic value than the grade. You never forget this stuff. Stage has a more prognostic value than the grade. And if they list some property of a cancer together, and they want to ask you which of the following shows the poorest prognostic factor. Just go and pick metastasis. Metastasis to organs. Organ metastasis is what you are looking for. If you don't see that there, just go and look for lymph node metastasis. Don't pick big tumor. Don't be deceived and be picking tumor of 20 cm. Nothing concerns us. It can be 20 cm, but once it has metastasized, that is bad. So moving on to the hallmarks of cancer. So there are so many factors that cancer needs to develop. Now, those are what we call the hallmarks. Now, what I'm going to say here is that I don't need us to cram all these things. You don't need to cram it. All what you just need to do is to understand it. You don't never cram it. Don't make that mistake of cramming it. Once you understand it, it stays with you. So let us start with the first point, which is growth signal self-sufficiency. What they are trying to tell us here is that most of the tumors, depending on the type, they have a self-sufficient growth factor. So that means that they don't need to be stimulated for them to grow. So let us look at the pathway for growth. Number one is the oncogenes, the proto-oncogene. So proto-oncogenes are just like growth factors. For example, platelet-derived growth factor. Another example, epithelial-derived growth factor. There are so many, plenty growth factors. So you have some tumor that have the ability to self-produce growth factors to drive their growth, such as some brain tumors producing platelet-derived growth factor in an autocrine approach. So just keep producing their growth factors, and they keep proliferating. So once you have a mutation in, so now what codes for that growth factor is what you call proto-oncogene. Oncogenes are just like growth genes that allow for growth, proto-oncogene. But when they become mutated in an activated form, they become mutated, and that mutation is causing a gain of function. So there's something we call gain of function, loss of function. When you have a mutation that is causing a gain of function, that is, that mutation is allowing that gene to be overly expressed. So that means that if you have a gain of function mutation with proto-oncogene, you are going to have increased elaboration of growth factors, and that will drive that tumor to develop. And an example of that is glioblastomas that expressed, platelet-derived growth factors. Now, in some situations, growth factors work by binding to growth factor receptor. So that is where some cancers will now wait. That okay, we don't need to elaborate proto-oncogene and convert them to oncogene. So once you have a gain of function mutation of a proto-oncogene, they become oncogenes. Let me state that. So proto-oncogene is not cancer. Once it changes to oncogene, then it becomes cancer. So some proto-oncogene will just be stimulating their receptors. They will just have a gain of function mutation of the growth factor receptors, such that the receptors will be working without any growth factor stimulating them. So an example of that is human epidermal receptor 2, HER2, in breast cancer. So we tend to, do more like chemical analysis, for this receptor to know what treatment you are going to be giving, right? So because HER2 is highly expressed in some form of breast cancer, and it is a growth factor receptor. So we need a gain of function mutation of this receptor to have, development of this cancer. Now, after a growth factor have, binded to a receptor, they can activate some signaling molecules. And an example of that is the RAS. Now, what does the RAS do? Once RAS become activated, what it's going to do is that it's going to become bound to GTP. So once you have, let me draw something. So this is a growth factor. This is a growth factor here. So you can have tumor developing because you are overproducing this growth factor. Example of that is what? Brain tumor elaborating platelet-derived growth factor. This growth factor normally, to promote growth, they would bind to their receptor. Now, some tumor develop due to overexpression, gain of function mutation of this receptor, to facilitate increased growth, a constitutive signaling without any need for growth factor to come in. They are overfiring. An example of that is what? HER2 mutation in breast cancer. It is a growth factor receptor. Now, if you don't have mutation of growth factor, you don't have mutation of growth factor receptor, you can have a mutation of the product of growth factor receptor interaction. And the product is what you call some signaling molecules. An example of that is RAS. Now, if your growth factor interact with the growth factor receptor, they can release RAS. And what RAS will do is that to become activated, it is going to bind to GTP. So GTP is needed. I'm sorry I don't have too much space here to write, but just try and follow me. So RAS will bind to GTP. RAS binds to GTP to become activated. RAS binds to GTP to become activated. Now, when RAS becomes activated and it activates transcription factors, RAS needs to be quietened. And what will happen is that you have activation of a RAS GTPase that's going to come in, and it will break down this GTP to GDP. So when RAS is coupled to GDP, it is inactivated. It is inactivated. Now, you have some form of RAS mutation that keeps it in the RAS GTP form. It does not allow you to be broken down. So in that way, it will keep firing in the growth factor signaling pathway, allowing for growth. So that is one pathway by which RAS mutation can lead to malignancy. So you have overexpression of RAS coupled with GTP. So in that form, it is always in that growth factor signaling pathway, activating transcription factors. Now, what will transcription factors do? Transcription factors will just come and be increasing expression of some certain genes. And what does this gene code for? They code for protein that drive cell cycle progression. An example of that transcription factor is going to be Mike. We have the C mic, the N mic. They are transcription factor. When you say transcription, meaning increased expression of a gene. And what gene are we talking about? Gene that codes for protein that increase growth. So you can have a mic mutation, gain of function mutation of mic, that will just constitutively be activating your cell cycle protein. Now, the last is cell cycle regulators like cyclin and CDK. Now, for these ones to promote growth, what do? You have your cyclin protein 1. It can bind to what? To CDK, cyclin dependent kinase 4 and 6. 4, and 6. Now, when it binds to cyclin dependent kinase 4 and 6, what they will do is that they would phosphorylate, because they are kinases. They will phosphorylate what? Anybody knows from biochemistry? Let me even see if you can remember. They
Retinoblastoma.
phosphorylate retinoblastoma.
Retinoblastoma.
And when they phosphorylate retinoblastoma, what do you think will happen? Retinoblastoma will just drop off what? Anybody knows? E12.
E2F.
E12. And E12 will just go and increase expression of protein that you need for DNA replication in the S phase. So E12 is going to allow your progression from G1 to what? To S phase. It is as simple as that. But everything culminates from this point to this point. It starts from this point to this point. So you can overexpress this, overexpress this, overexpress this, overexpress this, overexpress this for cancer to develop. So that is growth factor signal self-sufficiency. The next is anti-growth factor signal insensitivity. Anti-growth factor or anti-growth signal insensitivity, meaning that they don't respond to anything that say they should not grow. Anything that say they should not grow, they will not respond to it. They are deaf to it. And what are the things that will make a cell not to enter growth phase? That's when you start talking about your retinoblastoma. Your retinoblastoma is a gatekeeper of your G1 S phase. It doesn't allow progression from G1 to S phase. But what can tumor do to this retinoblastoma to allow it to make them grow. So what they do is that they do a loss of function mutation. So they will cause a mutation of the gene that codes for retinoblastoma, making it lose its function. So you need to provoke a loss of function mutation of retinoblastoma so that retinoblastoma is going to stop working, so that you can have progression from G1 to S phase. So mutations of tumor suppressor genes like retinoblastoma can be an hallmark of cancer. Also, it also makes sense for us to say that mutation of loss of function of E-cadherin can also cause cancer, because if there's mutation of E-cadherin doesn't work again. There's no addition between the cells. And when there's loss of contact inhibition, what happens? The cells release metalloproteinase and they start lysing the basal membrane. And there is what? Cancer. And an example of that is when you talk about the neurofibromine. Sorry, not neurofibromine now. The myelin mutation, NF2 mutation. So NF2 mutation is neurofibromatosis type 2 mutation that encodes a protein that I call myelin. Now, myelin is important for E-cadherin to function. Mutation of myelin, loss of function mutation of myelin leads to loss of, cadherin, E-cadherin effects. There's loss of contact inhibition and there's malignancy. The next one is evasion of apoptosis. For cancer to develop, there should be a means for them to evade apoptosis. And how do they evade apoptosis? They just go and deal with those factors that control apoptosis. For example, TP53. We know that TP53 is the one that induces apoptosis. So cause a loss of function mutation in TP53. So there's nothing that can provoke apoptosis again. So a loss of function mutation of TP53 is going to lead to cancer. And we're going to talk about the Sabla syndrome shortly. I don't know if Dr. Babarida have mentioned Sabla. Have you heard of Sabla before? Anybody? Anybody?
Yes. Yeah.
Yeah, so Dr. Babarida has talked about Sabla. So that is due to T53 mutation. Another one is BCL2. Anybody remember the function of BCL2? What do we say BCL2 does?
Anti-apoptotic.
Anti-apoptotic factor. So if BCL2 is an anti-apoptotic factor, so what do you need to do to it? So that means that you need that BCL2 to lose its function, and to gain its function rather. So that, sorry, I made a mistake. So if BCL2 is an anti-apoptotic factor, so that means that for you to trigger malignancy, do you need it to lose its function or for it to gain its function? Anybody?
Gain its function.
Yes, you
Gain
need
its
it to
function.
gain its function so that the cells do not die. And that brings us to the follicular B-cell lymphoma that we talked about, the 1418 translocation, leading to a constitutional activation of your B cells because they don't die due to your overexpression. Please look at the word though. Overexpression of BCL2 was what we said that day. While we have under expression of what? TP53. Yeah. So under expression of TP53 means that there's nothing to provoke apoptosis and the cells will live forever. So that is a loss of function mutation. But you need a gain of function mutation of your BCL2 for it to overly expressed and lead to cancer. The next is limitless replicating potential. They are replicating forever. And this brings us to the concept of telomerase. I know that we remember from biochemistry, telomerase is a short nucleotide sequence that they're added to the terminal portion of the chromosomes. And who remembers the base sequence that makes up telomerase? Anybody knows?
The T G G.
Ah,
Tag.
tag.
TTAGGG.
Okay, yeah, that person is correct. Tag. So what I
Tag,
have
yeah.
here is the mRNA equivalent. So if you change it to DNA, it's going to be TTAGGG. Can we see what I have on my
GGG.
screen? So once you have that, can we see what I have on my screen? The AAUCCC.
Yes.
So once you transcribe that to DNA, because this is RNA form, so that's going to be TTAGGG. So once you see that, that is telomerase. Now, normally when a cell is replicating, With each replication, you have a reduction in your telomeres. Now, when it reduces to a certain level, what will happen is that the cells will label it as being aged. That, okay, this is an aged or
Baba,
aged.
can you show it again? I hate to take you back. I know it's TTAGG, something like that. I just want to see yours.
So TTA GGG.
Mm-hmm.
TTA GGG. That's a DNA equivalent. This one I'm showing now is mRNA. Do you understand?
Okay.
So when the telomeres get shortened to an extent, the cell will label it as being aged, and they will just take it out by apoptosis. But what cancer will now do is that okay, that is what normally happens, Abby. So they will now reactivate telomeres. So that the telomeres can lengthen the telomere. Sorry, what we are supposed to say is telomeres, not telomeres. Telomeres is a sequence. Telomeres is an enzyme. So the telomeres is now going to be overexpressed, so causing lengthening of the telomeres, so that the cells will not be able to label them as being aged, and they will not trigger apoptosis, so they will live forever because the chromosomal ends will not shorten. Do we understand that? Does it make sense to us?
Yeah.
So moving on to sustained angiogenesis. So in sustained angiogenesis, what we are just saying that you just need blood vessels to nourish that tumor for a long time so that it can keep proliferating. And that brings us to a factor that we call the vascular endothelial growth factor, cytokine. So anyone that have overexpression of this guy would have increased vasculogenesis and angiogenesis that will provide blood vessels that will nourish that cancer forever. Or you have a reduction in the inhibitory factors for this guy. So if you drop anything that inhibits this guy, that means that this guy will live forever and you have a lot of production of blood vessels. So this can be produced by the tumor or by the stromal cells. Now, there are two types, of the forms by which these vessels can grow. You can either grow them from existing capillaries, or you can grow them from recruiting endothelial cells from the bone marrow. Now, the way I remember it is just that I just look at the terminology. If new vessels sprout from existing capillaries, so I'm going to call that new angiogenesis. So new for the new vessels sprouting from new capillaries, from old capillaries, which is the angio. So the old capillaries are the angio. The new is the new vessel. So new angiogenesis stands for capillaries growing from the existing new vessels growing from the existing capillaries is new angiogenesis. But for vasculogenesis, it means that I'm just recruiting endothelial cells from the bone marrow. But mind you, the vessels can be very leaky and they can be dilated. They'll be abnormal. They'll be very abnormal. So do you understand that? Can we use that logic to remember the nomenclature? Is clear?
Yes.
Okay. Then moving on to the Warburg effect. So Warburg effect is very simple. They can ask you in your exam. So which of following is one of the hallmarks of cancer? Warburg effect. And what are we saying? In Warburg effect, it means that the cancer cells will prefer to metabolize their glucose through the anaerobic pathway rather than mitochondrial oxidative pathway. Even despite the fact that there's presence of oxygen. And why are they doing that? If you remember, if glucose is subjected to oxidative phosphorylation pathway, it's going to oxidize the glucose to what? To CO2 and what? Anybody remembers?
Water.
What's your question?
CO2 and water. So that's going to be the product of oxidation of glucose following the oxidative phosphorylation pathway. But the cancer cells, they need carbon to grow. They need carbon to produce more DNA, more RNA, for them to grow. So that's why they will not be wasting their glucose and be converting it to CO2, but they will rather convert it to a substrate that has more carbon than CO2. So that's why they prefer to undergo anaerobic pathway. So which is undergoing aerobic glycolysis. So that means that they're undergoing glycolysis in the presence of oxygen. so that they can be produced, they can be converting their glucose to what? To what's the product of glycolysis, final product?
ATP.
No, that's not what I mean. ATP is produced in both oxidative phosphorylation and glycolysis.
The pyruvate.
Yeah.
Pyruvate.
So your
Pyruvate, yeah.
pyruvate that can go to lactate. And you know that
Mhm.
pyruvate and lactate, they have more carbon than CO2. True or false?
True.
True.
Mm.
So they can use that carbon for production of their cellular structures, like DNA, their RNA. That is Warburg effect. Go and write it somewhere and don't forget it. Can be tested.
Can you
Explain
explain it again, please?
Okay. So what we are saying is that the tumor cells, they need carbon. Carbon to form RNA, carbon to form DNA so that they can replicate fast. Now, they would prefer to shift their metabolism of their glucose from mitochondrial oxidation, that is oxidative phosphorylation, to glycolysis. Why? Because in oxidative phosphorylation, glucose is converted to what product? What's the final product of oxidative phosphorylation?
Water.
CO2 and water. That
CO2
is the
and water.
product. CO2, water, and ATP. That is it. CO2, water, and ATP. CO2 only contains one carbon. So instead of them doing mitochondrial oxidative phosphorylation, what they will do is that they are going to channel their glucose metabolism to glycolysis, even in the presence of oxygen. So that's why we call the process aerobic glycolysis. Are we following?
Mhm.
So the
Yeah.
product of aerobic glycolysis is going to be what? Pyruvate and lactate. And these structures have more carbon atom than CO2. So that they can use the carbon from pyruvate and lactate to what? To produce new cells. Do we get that?
Yes.
Yes.
Thank you.
Okay. Immune invasion in cancer. So what are the ways by which these cancers can evade immune system? Because you remember, what part of the immune system attacks cancer? Which cells?
CD8.
Cytotoxic cells and NK cells.
CD8.
Yeah. So the
And
cytotoxic
NK cells.
the cytotoxic T cells, and maybe natural killer cells, they are there to attack the cancers. But this is headache for cancer. So that means that for cancer to thrive, they must find a way to deal with the cytotoxic T cell. So they have developed for themselves three escape mechanisms. They've developed for themselves three escape mechanisms. And number one is that they will downregulate the MHC class 1 on the tumor cells. So MHC class 1 is going to be downregulated, by the tumor cells, so that your cytotoxic T cells will not be able to recognize, the tumor cells. Does that make sense to us?
Yes.
Yes.
So the second thing is that they will release immunosuppressive factors like transforming growth factor beta, so that you can dampen the immune response. We know that we have said it that transforming growth factor beta is a what? Is an anti-inflammatory mediator. So if the tumor cells are pouring out this guy, do we think any inflammatory response is going to happen?
No.
No.
So the third mechanism is to upregulate some immune checkpoint molecules. So now I'm going to go to that immune checkpoint and I'm going to explain it once and for all. So this phase is what we call the immune checkpoint. Now, I know that on the right, we can see the antigen presenting cells that are always expressing the type MHC2. And the MHC2 is always recognized. Any protein on this MHC2 projected by the antigen presenting cells is always recognized by the receptors in the what? In the T cells. Now, there's another thing we call the co-stimulatory signal. Hope we still remember this from immunology.
Yes.
Yes.
And that
Yes.
is a B7 from the antigen presenting cell
And
activating the
CD28.
CD28 in the T cell.
CD28.
Mhm.
Now, all this interaction is to activate and proliferate your T cell, getting it ready for inflammation. Now, what is this tumor going to do to dampen this inflammatory stuff? Now, tumor cells release what you call PD ligand. But don't forget, your T cells, they are the principal director of inflammation. Your T cells are the principal director of inflammation, so that is why they express your PD, principal director, which is going to bind to your PD ligand expressed by the tumor cells. Now, whenever you have this interaction, it suppresses T cell activation. So that means that one way by which tumors are trying to avoid inflammatory drive is that they are going to express PD ligand that's going to interact with the PD. The PD ligand 1 interacting with PD1 on the T cell dampen T cell activation. That's one way they can do it. Do we understand that? Then,
No, please, can you take it again? Sorry,
so
please, I didn't understand.
I talked about PD ligand being expressed by the T cells, by the tumor cells. And I talked about the T cells being the principal director of inflammation, and they release PD, which is the principal director. So the interaction between PD ligand and the PD of the T cell leads to suppression of T cell activation. So this interaction must never occur. Do you understand that?
Yes, so,
Yes.
so that means constitutively the T cells already have the PD1.
Yes.
No.
They
Okay.
have it.
Thank
They have
you.
it in them. But if you don't have any tumor available, you won't have any interaction.
Interaction. Okay.
Yeah.
Thank you.
So the other way by which the tumor cells they dampen this T cell activation is that they will now come that okay, there's a co-stimulatory signal B, they will now overexpress your CTLA4. Is that clear to us? They would overexpress a CTLA4 that is now going to compete for B7, with CD28. So it's going to compete with CD28 for B7 on the antigen presenting cell. So if mistakenly your CTLA4 interacts with B7, your co-stimulatory signal is lost. So that means that your T cell will never be activated. So, my people, does it make sense for us that if we want to destroy this tumor cell, does it make sense for us to use a drug that can bind to PDL1 and block it?
Yes.
Does it make
Yes.
sense for us? Does it make sense for us to develop a drug that can bind to PD1 and block it?
Yes.
Yes,
No.
yes, yes.
Yes.
Because you don't want that interaction to happen.
Interaction.
Does it make sense for us to develop a drug that blocks CTLA4?
Yes.
Yeah.
Yes.
Yeah.
So that comes to drugs like ipilimumab. If you don't know any drug here, please know ipilimumab. Ipilimumab. They might not test it directly, but they can test it by mentioning the concept of CTLA4. So develop an antibody that has affinity for CTLA4, occupying it and preventing, allowing the co-stimulatory signal to proceed with activation of the T cell, right? And also, you can also develop some other antibodies. So these antibodies are very difficult to know, but the way I just try to, learn it, you divide the T cell into half, semi. If it's only semi, you remember, that is fine. It's very unlikely that they will test it. But me, I just like, covering all the hands. They will not. USM doesn't like testing name of drugs. They will test the concept, not the drugs. So they can say that you should give antibody that can bind to PD1, not them putting CM pill map in the option. I don't know if we understand what I'm trying to say. They will not say that. They will not put, if they want to say that, okay, so which of the following mechanism is, the body can we use alternatively to, to prevent tumor escape? So they would say that, develop a drug or antibody that can bind to and block PD1, develop a drug that have the ability to bind to B7, blah, blah, blah. They're not going to put the name of the drug there, like CPD. So you just know it for academic stuff, but understand the pathophysiology. So, Semi, Plimab, and Pembrolizumab. So, Penumbra, both of them are PD1 inhibitors. While your PD ligand inhibitors, are drugs that bind to the PD ligand on the tumor cells. For example, because the tumor cells tries to cover itself with a duvet, so durvalumab, 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 durvalumab. Okay, so somebody's calling me. We start in class. Who's this? Please, somebody should help me put it on the page that the class is ongoing. That I should join.
I think they're waiting outside. They're waiting outside.
Okay.
You should try inviting them in.
Yeah.
Nobody is outside. Nobody is outside.
Okay. Why is this man just calling like that? Okay, so
Dr. Baba, can you go through your mnemonic again? It will help. The duvet, are they the middle one, the blue ones, not the green? So you're not.
yeah, so sorry, the mnemonic, right? So like I said, the first one is semi-plumab. So T cells is divided into half. Semi. You don't need to remember the map, just remember semi. If it's only semi, you remember. You don't know, okay, once I see semi, I pick it. You know, and pembro. This is my penumbra. So penumbra, pembro, lizumab, lumab, like being the T cell divided into half. I just try to come up with something. It's not very easy to develop, in the mnemonic for all these things. And for the PD ligand one, the PD ligand is expressed on the tumor cells. And the tumor cells covers itself with a duvet. So you want to remember durvalumab. I think, you don't need to know everything. Just one or two. Yeah, okay. They are not likely going to ask you the drug. I'm serious. But the pathophysiology, the concept by which the way the drugs act is important. That is it. And don't forget ipilimumab. Ipilimumab is common and it blocks what? CTLA4. It blocks CTLA4. So let me go back to the last one, which is tumor invasion. So tumor invasion is still, one of those hallmarks of cancer, and it is due to loss of E cadherin function. We have talked about this. So once there is loss of E cadherin, there's loosening of the intercellular junctions, and what happens? Metalloproteinase is being released, which degrades the basement membrane and ECM, allowing the cells. So the cells now attached to the product of the ECM, which is a laminin and fibronectin we explained in dermatology, and from there they find their way across the cellular matrix and enter the vessel. That's it. It's as simple as that. Don't stress yourself. There's lots of E cadherin. The cell-to-cell contact is lost. There's release of metalloproteinase that will degrade the basement membrane and the extracellular matrix. Now, the cells will now come and they will start attaching to the component of this extracellular matrix like fibronectin and laminin, and through them they are going to move out and enter into the vessels. That is what? Tissue invasion. Now, metastasis is now when they have entered the vessels and they have now disseminated to other sites. So they can gain entry through the lymphatics or the blood. They can adhere to the endothelium, and from there they travel to distant sites. So there's something called homing. Homing is just the the tumor sites camping in a new region. So for example, if a colon cancer, or a liver cancer, let me say colon cancer, enters into the superior mesenteric artery or the inferior mesenteric artery, they can move, let's say superior mesenteric vein, because most of the time tumors don't travel through artery. Do we know why tumors don't travel through artery? Anybody wants to think about it?
The question, please.
Yeah, because artery is supplying the vessel, the organ. It is vein that is carrying blood away from the organ. So it means that the tumor will only live through the channel leaving the organ. Do you understand? A tumor can enter the organ, maybe can metastasize to the organ, maybe from the artery. That can make sense. But if a tumor wants to leave an organ and disseminate to that side, it has to leave to the veins. Do we get it? Because veins carry blood away from that organ. Do we get it? So now, once they now get to another organ, they would camp there they would proliferate there, and they will establish their stroma in that area. So that's what you call the homing. So that means that they feel at home at that area. So the site of metastasis is usually predicted by the site of primary tumor, and the target organ where they will home or where they will metastasize to is usually the first encountered capillary bed. So this makes serious sense. For example, that's why colon cancer, the most common site of colon cancer metastasis is what? The liver, because the blood is going to leave to the superior mesenteric vein. The superior mesenteric vein joins with the splenic vein to form what? Anybody. Superior mesenteric vein, runs behind the pancreas, joining with the splenic vein to form something. That structure is usually behind the pancreas like this.
The portal vein.
The portal vein. There's no catch. The portal vein. And that is what supplies the liver. So it goes directly to the liver. The first encountered capillary bed. Why some organs show tropism, that is, they just have affinity for some areas. The idea is not explained by the first capillary bed. It's just where they like going to. And that is lung cancer metastasizing to the adrenals. I'm going to mention it here. The commonest site where the lung cancer goes to is the brain, because the way I understand it is that the lungs is very close to the brain. The brain is up, the lungs is just directly beneath it. So if you see metastasis to the brain, think of lung cancer immediately. So moving on to the checkpoint, we have explained the checkpoint. I don't need to talk about it again. So we know it already. So moving on to cancer epidemiology, how common are these cancers? So the commonest cancer in the world is skin cancer. Don't fall that trap. Don't fall for the trap. Don't pick anything else. Commonest cancer in the world is skin cancer. And if you further want to break it down, basal cell is the commonest, followed by squamous cell, followed by melanoma. I want to ask some questions here, but we don't have time. Let me just move. So in terms of the other types, so what is the incidence and the mortality? Now, the incidence and mortality, thank God, they are the same thing. So we don't have to cram anything. Once you know the incidence, you know the mortality. Now, they are like the same thing, almost the same thing. Now, so for the males, the commonest cancer after skin is the prostate, because that is what males have that females don't have. Prostate. Then for the females, it is the breast. Males don't have big breast, but females have big breast. So it is the breast, that makes female different from males. So, and that is the commonest cause of cancer, the commonest type of cancer rather. So after skin, so prostate in males, breast in females. Then the other ones are the same. Lungs, follows second, and colorectal follows third. That is that. Then for mortality, you just do a reverse. So lung is the number one killer. Lung is a bad killer. So lung comes first, then you change it. Prostate comes second, then colorectal. Breast comes second, and colorectal. Breast is always second. Most of the time, breast will be second. Yeah. So then in children, they have problem with the blood and the brain. Problem with the lung and the brain. Lung, blood and the brain. Blood and the brain. Blood and the brain. Blood and the brain. In children. So number one killer cause is leukemia. Incidence, leukemia. Then followed by CNS tumor. Anybody knows? Can anybody name any CNS tumor that is common in children? Anybody?
Neuroblastoma.
CNS, not PNS.
Pilocytic.
Eh?
Primary
Okay.
CNS.
Astrocytoma.
Yes. I heard somebody say pilocytic astrocytoma. That's fantastic. Which other one?
Craniopharyngioma.
Craniopharyngioma. Nice, fair attempt. But there's another one. Fried egg appearance.
Oligodendroglioma.
Oligodendroma. Okay. Yes, there's another one again. Can I remember the histology of
Medulloblastoma.
medulloblastoma? Thank you. Medulloblastoma. Then the number 3 is neuroblastoma. Then same thing for the death, leukemia, CNS, and the neuroblastoma. So moving on. So the common cause of death is actually heart disease. That is why cardiologists are getting highly paid. So I know that most of us want to do internal medicine and want to go to cardiology. So the reason why they are highly paid is because heart disease is the commonest cause of death, while cancer is the second leading cause. So the incidence of cancer has been dropping in males because we males now, we are now changing. We are no longer smoking, but it has not changed significantly in females. In fact, there's now like rising cases of, female smoking now, unfortunately. So what are the, I think I have some questions that I've missed. So sorry. So let us check the hallmarks. Let's see if we can solve one or two here. A researcher is studying the ability of breast cancer to metastasize. Neoplastic cells obtained from 30 patients with stage 4 ductal carcinoma of the breast are tagged with fluorescent antibody. The cells are inserted into a medium resembling normal human tissue. After 2 weeks, all samples shows in vitro hematogenous invasion and migration away from the original site of insertion. Which of the following is the most likely responsible for the ability of these cells to metastasize? Anybody?
Is it related to the
Yes.
metallo?
Release of matrix.
That is very good. I remember when I showed this question, maybe like almost 2 years ago, 1 year ago now. People went for Ikaderin. They were not very careful with the overexpression.
Overexpression, yeah. That's
So
the first thing.
It's lost.
it's
Sorry,
lost.
please, I have a
Yeah.
question.
Yeah, loss of ectoderm.
Hello?
Okay, somebody.
What do you say about loss of polarity, cellular polarity?
Anybody knows that? What is loss of cellular polarity? Where do we see that? Okay, maybe I did not emphasize it. If anybody has any idea, I said it in the last class. I said you cannot be able to tell where is it up, where is it down because of something. That is in dysplasia. That is dysplasia. So you have loss of cellular polarity in dysplasia. Please add it. Let's add it to our notes. So somebody wants to ask a question. I'm with you, sir.
Yes. Good morning. Is the release of the matrix metalloproteinate same as the type 4 cholinesterase?
Same as what?
Type 4 cholinesterase, or what's it called?
Type 4 cholinesterase.
I think you mean collagenase.
Yeah, collagenase, yeah.
Yeah. So an example of a metalloproteinase is collagenase or hydrolase.
Okay.
So if you see any one of them, pick it. And we said they are metalloproteinases because they depend on what?
Zinc.
Zinc. You know.
Metals.
So that is it. So increase in NC ratio, what is that?
Dysplasia.
That's dysplasia.
That's dysplasia.
Dysplasia.
That's dysplasia.
Yes.
You know, upregulation of telomerase is just going to make them proliferate. It's not going to make them metastasize. Don't forget that there is different hallmarks of cancer. All of them do different things. So the question is very simple. Let's see what we have here. Okay, so I just brought this one randomly. A 59-year-old man with stage 4 cancer comes to the physician because of progressively worsening weakness over the past 3 months. She has had 10 kg weight loss during this period. BMI is 16. She's thin with bitemporal wasting. Which of the following is the most likely primary mechanism underlying this woman's temporal muscle atrophy? Anybody?
It's going to be potassium degradation of
Degradation of ubiquitin
So what is
proteins.
happening here? What is happening here?
Cachexia.
Cachexia, atrophy. And we talked about atrophy. We said, what are the principles of atrophy? Anybody wants to tell us what are the changes? What will happen?
Reduction in the cell structure and size.
The what?
Number.
The what?
Cell size and structure.
Decrease
Reduction in cell size.
Exactly. So let's just remind ourselves again. So we have to reduce the number. How do we reduce the number?
Maybe loss of blood supply.
No. Loss of
Being
blood supply.
Apoptosis.
Apoptosis.
okay.
You see, loss of
Oh,
blood supply.
autophagy.
Loss of blood
Protein
supply
synthesis.
is the initial stressor that is provoking atrophy. You know, remember denervation, loss of blood supply,
Mm-hmm.
loss of hormonal support, disuse, nutritional loss. You know, all those things are the stressor that will activate atrophy changes. But how do you now achieve that atrophy? Reduce the number of the cells by triggering apoptosis, number one. Reduce the size of the cell. And how do we reduce the size of the cell? Anybody remembers?
Decrease protein synthesis.
Yes, ubiquitinated protease degradation. What else? We talked about another thing.
Autophagy.
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 Autophagy. Yeah.
Autophagy. Autophagy. Yes. Then you finally reduce protein synthesis. That is it. Very simple. All these things, we just need to understand them. You don't need to cram anything. Just work with the principle. The cell size is due to increase organelles and increase protein. So if I can take out protein, cell size will reduce. If I can destroy the organelles, cell size will reduce. I can eat the organelles by autophagy. I can label them for proteasomal degradation. Very simple. So we don't need to cram anything. Just work with your principle. What are the principles of free radical insults? What does it cause? What are the three things?
Lipid peroxidation.
Peroxidation,
Lipid
protein
peroxidation,
modification, and DNA breakage.
DNA breakage, and what? There's one more.
Protein modification.
Protein modification. You can see that there's no catch in this thing. Very simple. So that's what you'll be working with. So common metastasis. All carcinoma should go to lymphatic. So the acronym is CLASH. All carcinoma should go to lymphatics, while all sarcoma should go through hematogenous. But you have an exception. And what is the exception? Fresh. So we have 4 carcinomas that go through hematogenous route. Ideally, carcinoma should be spreading to lymphatics, while sarcomas should be spreading hematogenously through clash. But you have fresh. That is the opposite. So 4 of them. So what is the 4? F. The F for follicular thyroid carcinoma. It is a carcinoma that spread hematogenously. This is how you do. I can ask you. The R is for renal cell carcinoma. So renal cell and hepatocellular carcinoma, they go together. They share so many things. Both of them, they can secrete erythropoietin. Both of them, they spread hematogenously. So once you know renal cell, quickly pick your hepatocellular carcinoma with it. So fresh, follicular thyroid, renal cell, the S. So you change it to C, which is a choriocarcinoma. This is one that people tend to forget, but don't forget it. Change it to C, choriocarcinoma. Then the H is hepatocellular carcinoma. Having said that, we have to talk about presence of tumor in some organs, and we are talking about 4 essential organs. And trust me, in your exam, they cannot go beyond this 4. Quote me anywhere. They cannot go beyond this 4. That's a common one they are going to test you on. So metastasis to the bone, to the liver, to the lung, to the brain. Whenever you see a tumor in any of this area, most of the time it is from metastasis. It is not from primary malignancy. So you don't typically have a primary malignancy developing in the bone, in the liver, in the lungs, or the brain. Most of the time, it is a metastasis that is going there. Now, we are now expected to know the common tumor that spread to all these regions. So let's start with the bone. But before I start, I want to give us a rule of thumb that in all the situation, the second most common cause of metastasis is breast. So common cancer, the second most common cancer that goes to the bone is breast. Second most common cancer that goes to the liver is breast. To the lung is breast. To the brain is breast. So that's settled. Now for the bone, the commonest tumor that spreads to the bone is prostate cancer, because prostate empties into the venous plexus of Bastin. Remember that stuff that runs to the vertebrae. So from there, it can easily get to the vertebrae, exoskeleton, and cause metastatic deposit. But the second one is now the breast. If you know these first 2, you are okay. That's what you need to know, just the first 2. Then lungs, kidney, and colon. So lung can go to the bone, kidney can go to the bone, colon can. And if any of these three go to the bone, they are usually osteolytic. They are bad. They lyse the bone. Now, so we need to classify them into the nature of the metastasis. Is it blastic? So most of the time, prostate and small cell carcinoma of the lung, they are very mild. They are gentle. Prostate is a very gentle cancer. Doesn't cause, lysis of the bone. So they will tell you in the question stem that the mass they are saying in the bone is sclerotic. That means it is blastic. So that means that tumor is depositing new bone in that bone, but that new bone is weak and it can easily break. So that's what we call a blastic lesion. So that is common to prostate cancer and small cell carcinoma of the lungs. But if it's lytic, it's going to be non-small cell carcinoma of the lungs, like maybe adenocarcinoma, squamous cell carcinoma, the kidney, and the colon. These ones, they are lytic, but they are not very common as prostate and breast. But if it's mixed, you think of breast. So for kidney, colon, non-small cell, they will tell you that the lesions, they are lytic, lytic. But for plastic, they will tell you they are sclerotic deposits. So you think of something milder, okay? Maybe prostate cancer or small cell carcinoma of the lungs. If it's mixed, breast. And they have affinity for axial skeleton, not appendicular. It will not go to the upper extremity, lower extremity, but the ribs, the vertebrae, the chest bone, and all those things. Moving on to the liver. I've said it. The commonest cancer that spread to the liver is which one? I've said it today.
The colon.
The
Colon.
colon. Passing through which vessel? Passing through which vessel?
Portal vein.
Portal vein. So once you have that, you cannot forget. Superior mesenteric vein to the portal vein. Then the second guy, of course, the breast is always there. So how do you know that it is a metastasis? You will see it in the question. They will tell you that the lesions are scattered all over the liver parenchyma. They are scattered all over the liver parenchyma. Then the next is the lung. So colon also goes to the lung, just like it goes to the liver. It also goes to the lung. Colon goes to the lung. Then the breast, is the second as usual. Then the kidney and prostate. So most of the time, for you to identify a met to the lungs, you see it in both lungs. Both lungs. Both lungs. Now the last is the brain. Which one commonly goes to the brain based on proximity?
So the lung.
Lungs.
The lung.
Lungs. Then the breast. Melanoma also has high affinity for going to the brain. We should remember that. And what is going to heighten your suspicion for a met to the brain is that the lesions are going to be deposited at the gray-white matter junction. Once you see this in a question stem, you can confidently say that this is not a primary malignancy of the brain. It is a secondary malignancy of the brain. So, I think there's a question here. I think it's one. It's very straightforward.
Dr. Babatala, can you repeat that? Did you say met to the brain will be seen in the gray-white area, the junction?
Yes.
Okay.
Yes. A 57-year-old man is brought to the emergency department by his wife 20 minutes after having a bad seizure. He had recurrent headaches and dizziness for the past 2 weeks. MRI of the brain shows multiple round, well-demarcated lesions in the brain, parenchyma, at the junction between gray and white matter. These brain lesions are most likely comprised of cells that originate from which of following organs? Anybody?
The lungs.
It's as simple as that. So if it's the bone, you think of prostate. If it's the liver, you think of colon. If it's the lungs, you think of colon. So moving on to the oncogenes. So I have said it initially. I said gain of function mutation convert what? A proto-oncogene to an oncogene, right? A proto-oncogene to an oncogene. Anybody wants to give me an example of a proto-oncogene from what we explained in growth factor signal sufficiency? Anybody?
Derived growth factor.
The what? What? I'm listening.
Huh?
The right gene.
No. So people are reading what is on the screen, but I just want to, test our understanding. From when I was talking about growth factor receptor sufficiency, those are
Okay,
proton
B
coaches.
cell two. I mentioned B cell two.
No.
HER.
Is it
H2.
Okay, HER2 will be a proton coaches
Yes.
because we said that it is a growth factor, receptor. So what else will also
Mm-hmm.
be a proton coating there?
Platelet derived growth factor.
So a growth factor. So a gene that codes for a growth factor is a proton coating. A gene that codes for a growth factor receptor is a proton coating. What else? So after the growth factor receptor interaction happens, what's the next thing?
Sigma.
C-Mike. So C-Mike is a proton coating. What else?
the
RAS.
RAS.
The
RAS.
RAS. The
Yeah.
RAS is a proton coating. Then you can now talk about the CD, CD kinase. You see, these are simple. You don't need to cram
CDC.
anything.
Secretariness.
You don't need to cram anything. So, but we have a lot of them. So we can start from the receptor. This receptor, what is all about this receptor? So we have a receptor that we call the receptor tyrosine kinase. That receptor is located within the membrane. If this is cell membrane, you have this receptor located here, connected to so many downstream structures that activate growth. And here in the transmembrane region, it has a tyrosine kinase activity. That is, it has affinity for dimerization and phosphorylation of tyrosine residues, activating, growth signals. That's the way it works. Tyrosine kinase activity, receptor tyrosine kinase activity. And the first on the list is ALK. Sorry, we don't have any mnemonic to be remembering all these things, but you just have to be familiar with it. ALK. The way I remember it, adenocarcinoma lung cancer. ALK, adenocarcinoma lung cancer. It is a receptor tyrosine kinase, and it can cause lung adenocarcinoma. This is an oncogene because it codes for a growth, receptor. The next is EGFR receptor, so epidermal growth factor receptor, otherwise known as ERBB1. It is also a receptor tyrosine kinase, and it can cause lung adenocarcinoma, just like ALK. The next is HER2, so that is known as ERBB2. So EGFR is ERBB1, HER2 is ERBB2. It is also a receptor tyrosine kinase, but this one is responsible for commonly breast cancer, but it can cause gastric cancer too. So don't forget, HER2 is what? For breast cancer, and it is a receptor tyrosine kinase. Then the fourth receptor tyrosine kinase that we have here is RET. RET. What you don't want to forget with respect to RET is the fact that it is implicated in the MEN2A and MEN2B. Then remember the P's of RET, because a pet, RET is the name of a pet. You must remember the P's of RET, which is a papillary thyroid cancer and the pheochromocytoma. All these things are also components of MEN2, the pheochromocytoma especially, right? It is only the papillary that is not there. What is the one that replaced papillary?
Medullary.
Medullary. Fantastic job.
Medullary.
So that means that it makes sense that medullary is part of RET, papillary is part of RET, pheochromocytoma is there, and the MEN2B. MEN1 is going to be another thing, which is menin, that I'm going to show us. It is not an oncogene. The next is the BCR-ABL. We are familiar with this BCR-ABL, right?
Yes.
Yes.
So what cancer does it cause?
CML.
CML. And what?
And the pattern.
ALL.
AL. So
sorry.
if BCR-ABL translocation is causing ALL, what does that tell us?
It has a worse prognosis.
Worse
Transformer.
prognosis. Fantastic job. Worse prognosis. Now, what is peculiar to this BCR-ABL? It is a non-receptor tyrosine kinase. So what do they mean? It means that this receptor tyrosine kinase enzyme is not coupled to any receptor. It is in the cytosol. So once you have any protein interacting in the cell that wants to drive mutation or growth, it will just bind to that tyrosine kinase, which is its BCR-ABL. And you have a constitutive proliferation without a need for any ligand binding to the receptor. So that's what you call it, non-receptor tyrosine kinase. It is cytosolic. Why a receptor tyrosine kinase, it is what? Within the membrane. Do we understand that?
Yes.
So you don't need anything to activate BCR-ABL for you to start working. It undergoes a constitutional activation. Once this translocation happens, the tyrosine kinase activity is constitutional. You don't need to bind to any receptor. It fires. So it is a non-receptor tyrosine kinase. CML and ALF. Another example of non-receptor is JAK2. Non-receptor tyrosine kinase. You cannot forget this. BCR, ABL, and JAK2, they are non-receptor carrier. And where do you see JAK2? Anybody wants to give me 3 conditions for JAK2? Hematology,
Polycythemia,
polycythemia
Fatima.
vera.
myelofibrosis,
That's what everybody usually remembers. People will now stop.
essential thrombocythemia,
Essential thrombocythemia.
Myelofibrosis.
Fantastic job.
Yes.
Fantastic job. Then primary myelofibrosis. Those are the 3 things.
Myelofibrosis.
Don't forget. Don't ever stop at polycythemia. Always go to town. In fact, hello? Somebody saying something. Okay. So don't stop at polycythemia. Mention the 3. Primary myelofibrosis, essential thrombocythemia, and polycythemia vera. BRAF. So BRAF is not a thyroxine kinase, but instead it activates serine or threonine. So it is a serine or threonine kinase. And I have a code here, which is brain meet MPH. BRAF is tested. BRAF can be tested. Very important information I've given you. So brain meets MPH. The brain meets MPH. So the brain for BR for the BRAF, the ME for the melanoma, ME for melanoma, the TS for the FAGA, it is a threonine serine activator. The N for non-Hodgkin lymphoma, the P for papillary thyroid carcinoma. Which other oncogene can cause papillary thyroid that we talked about?
Red.
The red. The red. Then the H for hairy cell leukemia. If you want to forget anything, don't forget hairy cell leukemia associated with BRAF and melanoma associated with BRAF. You cannot afford to forget those 2. Don't forget it. I have begged you. I am begging you, and I have begged you. Don't forget it.
Please, can you take the mnemonic again for the brain meeting?
The brain meets NPH. So the brain meets normal pressure hydrocephalus. Brain for the BRAF. The ME for melanoma. The TS for threonine serine. The N for non-Hodgkin lymphoma. The P for papillary thyroid, and the H for hairy cell leukemia. Do we get it? Hello?
Yes. The N is not Hodgkin's. Okay, thank you.
So the next is the c-KIT. So c-KIT, is a cytokine receptor, CD17, 117. And it goes for gastrointestinal stromal tumor, which is GIST, and mastocytosis. So don't forget it for mastocytosis. They can ask you, they can put a picture of mastocytosis, the way it presents, and they can ask you what is a gene that is responsible here, that is overactivated. c-KIT. Then the next is c-MYC. Everybody in this world knows c-MYC to be a transcription factor that causes Burkitt lymphoma. Everybody knows it. Everybody in the world knows it. It is common knowledge. Everybody knows it. There's nobody that doesn't know it. Okay. So you should not also be left out because everybody in the world knows it. So the next is the NMIC. It's another transition factor, and the name makes it very easy. Neuroblastoma for NMIC. Then the KRAS, which is couple that meet with GTP. We all know that KRAS is a couple that meets with GTP. GTP to become activated. So what is the couple? The CO is standing for colorectal cancer. The P is standing for pancreatic cancer. The L is standing for lung cancer. And the E is standing for endometrial cancer. If you don't know anything, don't forget colorectal and pancreatic. Anytime you see KRAS, think about gastrointestinal tumors, couple with GTP. Then the BCL2. BCL2 is under oncogene because before you can classify anything as an oncogene, you must make sure that overactivation of that gene would cause cancer. That is the word, overactivation. And we have said it that if you overactivate BCL2, that means that you are not going to be achieving apoptosis. There's going to be inhibition of apoptosis because this guy doesn't like apoptosis. And that can lead to some cancers, like follicular cancers and the diffuse B-cell lymphomas, because all these things are actually with chromosome 18, if I'm not wrong, chromosome 18. I think diffuse should be like, okay, I can't remember the translocation of diffuse. It wasn't mentioned, but follicular is 1418. I think maybe marginal is 1118. Do we remember all those chromosome stuff?
Yes,
Yes.
yes.
It's much like 11.
11:18.
So BCL2 plays a role in all those things. Moving on, let me see if we can answer a question here. A 51-year-old woman comes to the physician because of persistent cough and weight loss over the past 2 months. Yesterday, she coughed up blood is sputum. She does not smoke. Pulmonary examination shows decreased breath sound over the right upper lobe. The CT scan of the chest shows a mass in the periphery of the right upper lobe. And histological examination of his specimen shows CT-guided biopsy showing glandular cells with papillary components and signet ring that stain positive for mucin. Glandular cells with signet ring. You already have your diagnosis already. An activating mutation of which of the following genes is most likely to have occurred? What is our diagnosis from this?
Adenocarcinoma of the lung.
Adenocarcinoma of the lungs.
Yes.
So which is associated with adenocarcinoma of the lungs?
ALK.
ALK,
It's very
GFR,
simple.
EGFR.
Yes, ALK and EGFR. A 52-year-old woman comes to the physician 2 weeks after noticing a lump in her left breast. Examination of the left breast shows a firm non-tender mass close to the nipple. Mammography shows an irregular calcified mass. A core needle biopsy shows invasive ductal carcinoma. Genetic analysis of this patient cancer is most likely going to show overexpression of which of the following genes?
B2.
A2. So, but there's no A2 here. Which one are we picking?
BRCA2.
Ah,
B2.
oh my God. Why are we picking BRCA? Overactivation. He said
ERBB2.
ERBB2. ERBB2 is also known as HER2. HER2 is also ERBB2. So we are never going to pick BRCA because the word is what? Overactivation.
Overactivation.
So we are going to see where we are going to pick BRCA now. So moving on to the tumor suppressor gene. Now, before I leave, we have to emphasize that only one allele of a proto-oncogene needs to be mutated before it can be converted to an oncogene. So that means that if we have a gene that codes for a proto-oncogene to be located on chromosome 16, we only need one copy of that chromosome 16 to be mutated for which to have that condition. But for the situation with tumor suppressor gene, it means that both chromosome 16 need to be mutated. The one from the mother, the one from the father needs to be mutated. You have to have a loss of function mutation of both alleles before you can have a loss of expression of a tumor suppressor gene. So that's what we call the nothing to it apoptosis. And this was mentioned in relation to which condition? Anybody remembers? Nothing to it apoptosis. Hypothesis. Retinoblastoma. And retinoblastoma is a tumor suppressor gene. So that principle works for almost all of them. you must mutate both alleles to achieve that loss of function mutation. But for oncogene, just mutate one, the person is gone. So it's a problem. Now, starting with APC. Where did we mention APC?
The adenoma carcinoma
The
sequence.
FAB, the familial
Oh, yeah.
adenomatous polyposis condition. Now, what is peculiar to APC? APC is a tumor suppressor gene. It doesn't allow for tumor to occur. Why? Because it is a negative regulator of your beta carotene WNT pathway. You see, this pathway is a pathway for growth. So APC will come and suppress this pathway so that growth will not occur. But once APC is mutated, once you have a loss of function mutation of APC, once you have an under-expression of APC, it means that this guy will be activated and there's going to be cancer. But what cancer? Colorectal cancer. Because I shared with what? FAP. Very important stuff. Moving on to BRCA1 and 2. BRCA1 and 2 code for BRCA1 and 2 protein, and they are what? They are tumor suppressor gene. Why do we call them tumor suppressor gene? Because they repair double-stranded break in DNA. Do we get it? So that tumor doesn't occur.
Yes.
But now, if you have a gain of function mutation of BRCA1 and 2, that means that you have a lot of repair of double-stranded breaks. That means you will not have cancer. But if somebody has a loss of function mutation of BRCA1 and 2, that means that the function of BRCA1 and 2 is lost. There's no way they can repair DNA breaks, and there's going to be what? Cancer. Okay, so you don't want to forget BRCA causing breast cancer. You don't want to forget BRCA causing ovarian cancer. And okay, you can also remember pancreatic and prostate. But the first two are much more important. The next is cyclin-dependent kinase inhibitor, or what is it called? Suppressor, negative regulator of cyclin-dependent kinase, CDKN. CDKN, it is a tumor suppressor gene. I see CDKN as a fruit that we call plum. So CDKN2A is a plum fruit. So P standing for pancreas, L standing for lung, and M standing for melanoma. Which other mutation do we say is responsible for melanoma? Anybody remembers?
BRAF.
BRAF. So CDKN, is upregulate P16. Is also known as P16. So CDKN is also known as P16, and it blocks G1 to S phase. So if you delete CDKN in loss of function mutation of CDKN, there's no P16 again. That means progression to G1 to S phase can happen freely. So plum is going to ensue. It is going to pancreatic, the lung, and the melanoma. This is self-explanatory, deleted in colorectal cancer. So it can cause colorectal cancer. Okay? If you remember the adenomatous sequence, it's part of those guys. The next one is SMART4. SMART4 or DPC4. Both of them the same thing. They are deleted in both pancreatic cancer and colorectal cancer. So they can cause both of them. MEN1 is a what? Tumor suppressor gene. It comes from menin, and menin is a tumor suppressor gene. So anybody with menin mutation, loss of function mutation, can have MEN1. But anybody with RET, what type of mutation? RET, what type of mutation?
Overactivation.
What's the word?
Oncogene.
What's the word?
Gain of
Gain
function.
of
Gain of
function
function.
mutation. So anybody with RET, gain of function mutation, develops MEN2A and MEN2B. While anybody with MEN, loss of function mutation, will develop MEN1. Moving on to NF, neurofibromatosis type 1. So NF1 is also known as RAS GTPase. So you cannot forget this. NF1 is not a friend of RAS. So NF1 is an antagonist for RAS because it activates RAS GTPase. So if RAS GTPase is activated, anybody knows what will happen
To break down
RAS
GTP to GDP.
you
to
have
GDP.
inactivated.
So what will happen to RAS?
Inactivated.
So RAS will be
To
inactivated.
be
So
inactivated, yes.
if RAS is inactivated, will growth happen?
No.
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 So that is how NF1 is a tumor suppressor gene. Now, if you lose the activity of NF1, So that means that there's nothing to split GTP from RAS. So that means that GTP will keep binding to RAS and there will be what? Uncontrolled proliferation. That is how you have
Activation.
neurofibromatosis type 1. For type 2, the problem there is Merlin. What is Merlin? Anybody remember? I've mentioned it briefly. I want to see if we're actually following. I mentioned Merlin somewhere. It's a component of something.
NF2.
Yeah. So Merlin is a component
So
of something. Anybody remembers? Well, I know we might not be able to take it in at that point. So I'm going to mention it again. Merlin is a component of, it allows for icadherin to function. See, Merlin allows for icadherin to function. See, NF2 mutation, loss of, icadherin function. So Merlin allows for icadherin to function. So that means that if there's a loss of function of Merlin, icadherin cannot function. There will be loss of contact inhibition, leading to what? Malignancy, like NF2. So do you understand the difference between NF1 and NF2?
Yes.
can you get it again, please?
So do you understand that of NF1?
Yes. No,
So
the NF2, you understand the NF2?
so NF2 codes for Merlin or schwannomine, not fibromine, but schwannomine. Now, where is the problem with Merlin? That means that icadherin cannot function. Excuse me. Icadherin cannot function because icadherin needs NF2. Icadherin needs Merlin. So if you have a loss of function mutation of Merlin, icadherin is lost, and there's loss of contact inhibition, meaning there's what? Malignancy. Do you understand? Do we understand?
Yeah.
Okay. So
Can
the
we
next,
compare the other one, please?
yeah.
To
So
the NF1?
neurofibromine is a RAS GTPase activating protein. So what does it do? It splits GTP from RAS. When GTP is splitted from RAS, what do you think will happen to RAS?
Deactivated.
It will become deactivated because it will now be coupled to GDP. So that is how, NF1 coding for neurofibromine can suppress cancer. It will split GTP from RAS. But if you have a loss of function mutation of NF1, that means there's no neurofibromine again. There's nothing to split GTP from RAS. So what do you think will happen? Overactivation of RAS leading to what? To cancer. Do you understand that?
Yes.
Hello?
Yeah.
Yes.
So moving on to P10. So P10 is a negative regulator of PI3K-AKT pathway. You don't need to cram all these things. It's just like APC and WTN pathway. P10 is PI3-AKT. This is a growth pathway too. So if you take out P10, there's nothing to suppress this pathway. There's constitutional activation of this pathway, and there's cancer. So P10, just remember, prostate for the P, breast and endometrial. It's not very common, but that's just P10. Then here, retinoblastoma is very important. Retinoblastoma inhibits E12, and we have talked about this blocks T1. So that means that retinoblastoma can cause retinoblastoma and what? Osteosarcoma. Please, don't forget this stuff. Retinoblastoma mutation can predispose to both retinoblastoma and osteosarcoma. Please, be moving this stuff every day. Retinoblastoma can cause osteosarcoma. Very important stuff. TP53 activates P21 and blocks G12S phase, just like retinoblastoma. It does it through P21, not P16. P16 is CDKN through A, which is plum. T53 does it done by P21. And if you have a loss of function mutation of T53, that means you are going to be having unopposed progression from G1 to S phase, leading to Liefeld syndrome, that you also call the Sabler syndrome. So Liefeld syndrome, otherwise known as the Sabler syndrome, which includes S for numerous sarcomas. So just tell you that there's a family history of Sabler. The mother is having sarcoma, the younger sister is having B, which is the breast or brain tumor. The brother is having lungs or leukemia, and the father is having adrenal cancer. So you just using family history of any of these things. You know that the Sabla that they are testing you on, and the gene involved is the one coding for T53. So Li-Fraumeni syndrome, the Sabla syndrome, multiple malignancy at early age, including sarcoma, yes, the B for the brain and breast, the L for the lung and the leukemia, and also the A for the adrenal gland. So what tumor have a tropic effect to spread to the adrenal gland?
Lung.
The lungs.
The
Fantastic.
lungs, yeah.
So, tuberous sclerosis from neurology, the two genes, tuberous sclerosis type 1 and type 2 gene. Type 1 is amatine, type 1. And the type 2 is tuberin, 2 tuberin, TS2 tuberin, 2 tuberin. WVHL, sorry, I said WVHL, VHL, von Hippel-Lindau disease. So what is peculiar to von Hippel-Lindau disease? How do they present? Anybody?
They
So
they
renal
they present with hematomas,
renal cell
renal
Amatomas?
cell cancer.
Amatomas?
No,
hemangioma,
hemangioma.
Oh, sorry,
hemangioma,
Hemangioma or
renal
Renal
cell
cell
carcinoma.
renal cell
carcinoma.
carcinoma,
Renal cell
carcinoma,
carcinoma,
pheochromocytomas, and
pheochromocytoma,
pheochromocytoma.
hemangioblastoma of the retina, the cerebellum, the spine, blah, blah, blah. Renal cell carcinoma, vulnerable factor. Now, what does this do? This is a tumor suppressor gene that inhibits hypoxia inducible factor 1A. So that means that if there's a loss of function mutation in VHL, what do we think is going to happen to hypoxia inducible factor?
To increase, there will be hypoxia.
It will work. This factor will what?
To be activated.
It will increase, it will be activated. So if there's hypoxia inducible factor, so that means that there's going to be erythropoiesis, because the function of hypoxia inducible factor is to what? Produce new, to produce new red blood cells. So in the process, you are trying to produce new red cells. You are also trying to produce new vessels to contain the red cells. That is why you have hemangioblastomas, in people with VHL mutation. You have renal cell carcinoma. Renal cell carcinoma also elaborate erythropoietin, just like pheochromocytoma. Pheochromocytoma also elaborate erythropoietin. So all of them is because of this hypoxia inducible factor that is elaborated in there. Then the last is WT1 mutation, which is present in Wolff's tumor. So yeah. So moving on to let me see. I think we have a question here. Okay. A 53-year-old man comes to the physician because of 2 months history of multiple episodes of small amount of blood in his stool. Examination shows a pale conjunctiva. Hemoglobin concentration is 8.3. Mean corpuscular volume is 72. Colonoscopy shows a 2.3 blood mass in the ascending colon. The photograph of the biopsy is shown, which of following is important in the pathophysiology. So what type of anemia does this person most likely have?
Iron deficiency anemia.
Iron deficiency.
Yeah, I agree with you. Okay. Let's see the image. What do we have here?
It's like the village style.
Nice. So villous polyps. So with that,
Dr. Babawala, can you show that diagram again, please? Okay, thank you.
okay, can see. So what are we going for? Just read the options. Yeah. So why are you picking C?
Impaired degradation of
I think I want to consider under expression. Yeah.
No.
um,
No. We have not even talked about COX-2
Okay.
today. So if COX-2 is part of the adenoma carcinoma sequence, but it has to be overexpression, not underexpression.
Yeah, not under. Yes.
Okay. I missed that.
So
It's to be
so it is
stable.
C. It is C. So when are we
It's
picking? When are we picking? What's it called?
CK
CK
Mastocytosis or
or mastocytosis.
now.
Yeah.
or GIST.
Gist. Yeah.
Yeah.
What do we
Yes.
think? What do we think D is talking about? Anybody?
Is it the cycle independent?
ATP.
No. Let's check it again. Abnormal transfer of phosphates through cellular proteins. Phosphates.
That's
That's
receptor
cycle
tyrosine
independent.
kinase.
Yes. That is tyrosine kinase. So that's another way the question can come. That's how you have to apply your knowledge of biochemistry to all these things. So that's another way they might not put tyrosine kinase there. They can just put phosphorylation of, proteins or something. That's tyrosine kinase they're talking about. It could be serine, threonine kinase like BRAF. It could be tyrosine kinase. All of them, they phosphorylate proteins. So moving on to the carcinogens. So a lot of them, the first is aflatoxin of aspergillus. I know Dr. Abani will have mentioned this under the GI section, and it's very common in people that get exposed to grain and nuts, take a lot of granules, that is stored for a long time. They can grow the fungus, aspergillus, and that can be producing the aflatoxin. And once this aflatoxin is ingested, it gets oxidized. It gets oxidized by the cytochrome P450 system. And the next thing is that it is going to inhibit P53. And when there's inhibition of TP53, that means that you cannot have suppression of the G1 to S-phase progression. You have uncontrolled G1 to S-phase progression leading to hepatocellular carcinoma. There's a lot of causes for hepatocellular carcinoma. Aflatoxin is one of them. And you cannot forget that. Alkylating agents like camostin, like cyclophosphamide, they can cause blood cancer like leukemia and lymphoma because they cross-link DNA, right?
Yes.
Okay. Aromatic amines like benzidine, like 2-naphthylamines, they can cause bladder cancer. So if you see anybody exposed to any aromatic amine, maybe from working in a tech guy that they use dye, or the person is a smoker, because smoke contains 2-naphthylamine, they can develop transitional cell carcinoma of the bladder or urothelial cell carcinoma of the bladder. Arsenic. So I see arsenic as a very heavy metal. Arsenic is a very heavy metal. So that's why it's very common in people that smelt metals. People that smelt metals, they produce a lot of metallic particles that can be inhaled, leading to lung cancer. Arsenic is a very heavy metal. So it can be present in heavy wood to preserve wood. So wood is heavy. So wood preservation. And from there, it can come in contact with the skin, or it is a product of herbicides in people that work in the vineyard to grow their crops. It can get in contact with the skin, leading to squamous cell carcinoma of the skin. It can also find its way to the liver alongside with polyvinyl chloride. Arsenic and polyvinyl chloride are two common causes of hepatic angiosarcoma that you can never forget for your exam. So, arsenic is product of wound smelting, wood preservation, metal smelting, wood preservation, and herbicides, which can get inhaled to the lungs to cause lung cancer. It can get in contact with the skin to cause squamous cell carcinoma of the skin, and at the same time can get way to the liver, causing hepatocellular carcinoma. Asbestos, we have talked about asbestos almost 1,000,000 times during the course of our study. So it is present in roofing, as well as people that build ships, right? Other common causes include people that work mechanics, brake oil, brake pad, people that do insulating stuffs, because they can give you another scenario in your exam. So don't shake. They might not give you the typical roofing or shape, but they can give you mechanic, brake stuff, insulating. So all of them can lead to asbestosis and can cause lung cancer. And the commonest one is still bronchogenic, just like it has been emphasized. We talked about it in the last class. It is associated with a common risk for bronchogenic carcinoma more than mesothelioma, but it is the only cause of mesothelioma. So don't make that mistake of picking mesothelioma ahead of bronchogenic carcinoma. Don't ever make that mistake. Asbestosis will cause bronchogenic carcinoma 10 times more before causing mesothelioma. What about smoke? Tobacco smoke? Tobacco smoke contains true naphthylamine that can cause transitional cell carcinoma of the bladder. But the other ones is usually squamous cell. The cervix, squamous cell, esophagus, squamous cell, kidney, renal cell carcinoma of the kidney, larynx, squamous cell carcinoma, lungs, squamous and small cell carcinoma, oropharynx, squamous cell carcinoma, the pancreas, pancreatic adenocarcinoma. So you cannot forget that smoke is a risk factor for renal cell carcinoma. You cannot, because they can show you an image, showing that mass, and they will ask you, what is the risk factor in this patient? We want to ask yourself, is this person smoking? The same thing for pancreatic adenocarcinoma. Smoking is a terrible risk factor in both of them. You cannot forget it. Then people that smoke, they inhale the smoke through their mouth. So it can be a problem in the oropharynx, squamous cell carcinoma of the oropharynx. Goes to the esophagus, squamous cell carcinoma of the esophagus, as well as adenocarcinoma too. It goes to the airway, larynx, squamous cell carcinoma of the larynx. It finally settles to the lungs and cause what? Squamous cell carcinoma and small cell carcinoma of the lungs. It is only cancer of the lung is not shared with smoking?
Adenocarcinoma.
Adenocarcinoma. So adenocarcinoma, pay attention to that. Smoking also increases the risk of squamous cell carcinoma of the cervix, not adenocarcinoma, squamous cell carcinoma of the cervix. So if you see someone that has adenocarcinoma of the cervix, what risk factor can we think about?
The
Anybody?
steroid.
Steroid?
That is
No.
still Sylvester.
Yes, there's exposure. There's exposure. Very important stuff. Ethanol. So people that are drinking, they drink to the mouth, esophagus, squamous cell carcinoma of the esophagus. It gets to the liver, damage the liver. So if you do an experiment, you can buy meat from the market and pour alcohol. You see the way it fries the liver. It fries it. So it can cause a hepatocellular carcinoma of the liver. Then the breast cancer too is commonly associated with alcohol intake. Ionizing radiation, just two cancer. We have talked about this so many times. The first is leukemia. The second is papillary carcinoma of the thyroid. We talked about it when we were talking about free radicals. Don't forget. Ionizing radiation is a problem in the blood causing leukemia, as well as thyroid gland, papillary thyroid gland. Majority of people that develop papillary cancer of the thyroid have had some form of radiation exposure in the previous years. Don't forget about the metallic dust from occupation. Occupational, dust like nickel, chromium, beryllium, silica. They can be ingested. They can be inhaled rather. Nickel, chromium, beryllium, silica dust. They can be inhaled and they can cause lung cancer. Lung cancer. Nitrosamines, we have talked about it in our GI section. Smoked foods. So just like these Japanese people that like taking smoked foods, they develop gastric cancer. It's very common in them. That is why they are the one that develop staging for gastric cancer. It is their cancer. So it's very common in people that takes a lot of nitrosamines from smoking. And the type of cancer they develop is the intestinal type. What is the other type? Anybody?
Diffuse.
Diffuse. Which one is
Sickness.
associated with Linnitis plastic?
Diffuse.
Yeah, it's the
Diffuse.
gas.
Excellent. Excellent. Radion. Radon is the second commonest cause of lung cancer, and it occurs due to breakdown of uranium radioisotope. So it settles under the basal membrane of maybe the floors, the scaffolding and the likes, and it can be easily inhaled. causing lung cancer. It's the second commonest cause of lung cancer after smoking. Nothing else but radon. Vinyl chloride works together with arsenic and they can cause hepatic angiosarcoma. So both of them can cause hepatic angiosarcoma, and vinyl chloride is a product of pipes. They use it to make pipes, polyvinyl chloride. So people that take all this water from pipes directly, they can develop hepatic angiosarcoma. So there's a concept that we call food cancerization. It means you don't need to worry yourself. What they are just trying to say is that when you have a lot of space being exposed to a particular carcinogen, you can have different multiple primary cancers developing independently. So that means that what we are saying is that you have, like, let's say that this is skin, and all the skin, they're exposed to um, they're exposed to ionizing radiation here, 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 like this. So this one will develop its own cancer. This one will start undergoing some precancerous changes. This one too. Now, the cancer that we are seeing here, 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 does not mean that this one is the one that spread to this area. No. It means that this field collectively was exposed to the carcinogen and they are developing the primary cancers independently of one another. That is what you call field cancerization. So it's very common in the skin, and the most common example that they usually use is head and neck. So you cannot forget. So somebody develops squamous cell carcinoma of the mouth now, and later they start seeing some lesion developing elsewhere in the mouth. It is actually due to the concept of field cancerization, not usually metastasis. So don't pick metastasis in the question. Don't ever pick it. So people that have oropharyngeal cancer, which is a form of head and neck cancer, following smoking, they can develop numerous cancer from field cancerization, skin cancer too from UV light, excuse me, as well as uroepithelial, carcinoma from bladder. So don't forget bladder cancer, very common in people that smoke. Number one, people that they are usually old more than 60 years, they are smokers. Step two, you will see all these things. And people that work in textile industry, so they have a lot of transitional cell carcinoma developing. But people that get exposed to maybe chronic cystitis or chronic schistosomiasis infection, their own bladder cancer is going to be squamous cell, not transitional cell carcinoma. So we have to pay attention to the differences. So moving
Can
on.
you repeat that last part again, please? The difference between the squamous cell and transitional for bladder.
So when there's chronic irritation of the bladder from maybe the person had a chronic cystitis that was unresolved for a long time, or the person has schistosoma hematobium infection, the type of cancer they are going to develop is squamous cell. But if the person has exposure to dyes, smoking, the kind of cancer in them is going to be the normal epithelium cancer or the transitional cell cancer. Do you understand that?
Still in the bladder, huh?
In the bladder, yes. The normal epithelium of the bladder is uroepithelium or transitional cell. So, but when it changes, so people with squamous cell, people with schistosoma hematobium or cystitis, you are going to have a metaplastic change first. Do you understand? From transitional to squamous cell to cope with that irritation before it now becomes cancer. Can we appreciate that now? Do you understand what I'm saying?
Yes.
So that is the way it occurs. So oncogenic microbes. Is there a question here? Okay, let me see.
Can I ask you, can I take you back a little? Okay, the transitional cell and uroepithelial are normal cells of the bladder.
Yes.
So how come the squamous cell, which part of the bladder is it on for us to have a squamous cell carcinoma?
So it's just like irritation of the transitional cell of the bladder from the infection, the hematobium. So when there's irritation of the transitional cell of the bladder, it's going to undergo metaplasia. Do you remember that part? Metaplasia
Yeah.
to
Yeah.
Squamous cell can withstand irritation compared to transitional cell. And
Okay.
we know that metaplasia can progress to what? What
Can
does it progress?
progress.
To what?
Dysplasia.
Dysplasia.
Neoplasm.
Exactly. Metaplasia can go to dysplasia, and from dysplasia to what? To carcinoma. That is it.
Carcinoma.
So that's the way it
Okay.
is.
Now, in this squamous cell one, is it coming from the urethra, or because it got to be a transition from somewhere to somewhere? If we're saying that it's metaplasia that brought about the squamous cell carcinoma in the bladder,
Yes.
because there's no part of the bladder that has normally a squamous cell, isn't it?
Yeah, that's why we're saying it's coming from metaplasia. There's a
From
transitional
where?
cell. Hematobium infection comes in. The hematobium irritates that transitional cell epithelium, changes it to metaplastic change, changing it to what? Squamous cell epithelium. But that squamous cell epithelium is not yet cancerous. If the irritation continues, the metaplastic change will not be able to hold on to it. It's going to progress to dysplasia. That is squamous cell dysplastic changes. Then, if the irritation continues, the dysplastic changes in the squamous cell is going to change to what? To cancer. Because don't forget, where's my marker? Don't forget, dysplasia is just talking about changes that occurs in a particular segment. So if this is the entire bladder, transitional cell is lining it, right? And suddenly there's infection. Infection is chronic, it will change to metaplastic change, which is what? From transitional cell to squamous cell. All of them will be replaced by squamous cell. Everything here will be squamous cell. Everything here is squamous cell. If the irritation continues, changes of dysplasia is going to start happening in this squamous cell, which is pica. So you start having pica starting from these cells here, progressing downwards to these cells here, then finally getting to the basal membrane cells. When it gets to these cells of the basal membrane, what stage is that?
CIN3.
That's the CIN3. Now, CIN3 is irreversible or reversible? Anybody?
Irreversible.
So that means that there's going to be a breach of this epithelium, and it's going to become what? What afterwards?
Oh,
Invasive.
invasive carcinoma.
Invasive carcinoma, but which type? Which type? Is it squamous? Is it transitional? Is it adenocarcinoma?
Becomes squamous.
Squamous. So, Doc, do you understand it now?
Yes.
So
Thank you.
that's just the progression of all these tumors. That's the way they move. So
Your last question.
yeah, okay, sorry. So a previously healthy 48-year-old man comes to the physician because of a 2-month history of weight loss, yellowing of the skin. Works at a farmer and cultivates soya beans and corn. He does not smoke, take alcohol, or use illicit drugs. Vital signs are normal. Physical examination shows sclera, icterus, and tender hepatomegaly. Ultrasound shows 5 cm nodular lesion in the right lobe of the liver. Further evaluation of this lesion confirms hepatocellular carcinoma. The activity of which following enzyme is most likely contributing to the pathogenesis of the patient's condition. What do we think is the cause of this hepatocellular carcinoma in this patient? Aflatoxin.
Yes.
Aflatoxins, yeah.
So what do we think will be involved from what we have mentioned?
Cytochrome P450.
Speaking monoxygenase.
That's very good. So your cytochrome P450 activate your aflatoxin. The aflatoxin will now inactivate what?
TP53.
TP53. So TP53 is now the one that will not drive that mutation. So that's the way it works. So we are done with the the carcinogens, I mean, the toxins.
So,
Moving on.
can you go back to that question? Is it just from the answer choices? Why did we rule out? It said works in the farm. That
Yeah, so they said
what, what
the
brought
activity
us
of which following enzyme
to,
contributed to
no,
the
the,
pathogenesis.
the the vignette itself?
Yeah,
What brought us to it being aflatoxin?
the farmer cultivates soya beans and corn.
Okay, okay, soya beans. Okay,
Soya beans
okay,
and corn. So it's present in
okay,
grains and nuts. Soya bean nuts and
yeah,
corn grains.
okay. Thank you.
You're welcome. So EBV, oncogenic microbes. EBV is associated with Burkitt lymphoma, which is an example of a non-Hodgkin lymphoma. It can also cause Hodgkin lymphoma too, EBV. It can cause nasopharyngeal carcinoma and primary CNS tumor, particularly in people that are immunocompromised. So you don't want to forget these four cancers with respect to EBV. Burkitt, which is a non-Hodgkin, Hodgkin lymphoma, nasopharyngeal carcinoma, and primary CNS lymphoma for Hodgkin. EBV and HBV, hepatitis C and hepatitis B, they cause hepatocellular carcinoma. That one is self-explanatory. Human herpes virus type 8, Kaposi sarcoma, can cause Kaposi sarcoma, particularly people with HIV. People with HPV 16 and 18, that's a high-risk serotype, can develop squamous cell carcinoma of the cervix commonly, but it is not spared in males. That is why at the age of 11 to 12, you must get a vaccine for HPV, whether you are male or you are female, because it can cause penile and anal cancer and cervical cancer. And at the same time, it can cause head and neck cancer. Very, very important. People that practice oral sex, they can develop head and neck cancer from HPV infection. Now, you have to know the way they cause the problem. It is very important because it elaborates, the 16 and 18 serotype elaborate oncoprotein E6 and E7. And E6 inactivates TP53 and E7 inactivates retinoblastoma. So the larger one is the one that takes care of retinoblastoma, while E6 is the one that takes care of TP53 and they will cause cancer. You cannot forget this for the sake of exam. Please don't risk it. Human papilloma virus causing cervical cancer, penile cancer, anal cancer. Once you see anal cancer, warty growth, you know that okay, this is HPV causing anal cancer as well as head and neck cancer. H. pylori is a cause of gastric adenocarcinoma and also Mott lymphoma. Liver fluke, which is clonogenic sinensis, is a cause of cholangiocarcinoma. So, cholangiocarcinoma, very important. Liver fluke is a cause of cholangiocarcinoma. Schistosoma hematobium is a cause of squamous carcinoma of the bladder, not transitional cell carcinoma of the bladder, but squamous cell carcinoma of the bladder. HTLV, which is human leukotropic virus, is also a cause of adult T cell leukemia and lymphoma that will be seeing the Sézary bodies. I should have asked that question. Who wants to describe the Sézary bodies to us? What's Sézary body?
Sorry, what did you
The Sézary bodies. Sézary.
Okay.
Comes with skin infection or skin problems, and
No,
also
what will be described? Okay, yeah, they can come with skin infection, very correct. So they have like pruritic papules, plaques. Yes. If you do a histology, what cells are you going to see?
CD4.
Yes. CD4 cells. Yes. Yes.
Okay.
They,
Are
they,
you
they will
talking
have
about
they'll have
cerebrum nuclei?
yeah, they'll have cerebral nucleus. That's what you are going to see in histology.
good for me.
Very important. So moving on to the serum tumor markers. So these guys are not used for primary tumor diagnosis. So you can't say that this is a mass now. It's likely to be liver cancer. Let's go and screen for AFP. You don't do that. They are not used in diagnosis or screening. we only use them after we have made our diagnosis and we want to monitor the recurrence of the tumor or if it's responding to therapy. That's how you use your tumor marker. You never use tumor marker to make a primary diagnosis. No. So if you want to make a definitive diagnosis, you have to do a biopsy, because sometimes you can even have an individual having elevated tumor markers and they don't have cancer, because it can be elevated in non-neoplastic conditions. Okay. So let's go for 15 minutes break so that we just come back and we just round up the entire program. So join me here at 12:45. Is that okay? Hello?
Yes.
Yes, thank you. Yes.
Tomorrow, Wednesday, isn't it?
Good morning.
Okay. So moving on to the tumor marker. So I've explained, and we have alkaline phosphatase, first word. So alkaline phosphatase is typically commonly secreted from the liver, from the bone, and the placenta. So those are three structures that produce alkaline phosphatase: the bone, the liver, the placenta. So if you see elevated alkaline phosphatase, you want to ask yourself, is it coming from the bone? Maybe there's a metastasis to the bone, or there's a metastasis to the liver, or there is maybe a cancer like seminoma producing plaque, which is placental, derived alkaline phosphatase, placenta-related alkaline phosphatase. So, what I just want to say here is that most of the time, what causes elevated alkaline phosphatase from the bone issues is when you have like a remodeling of the bone. There's a metastasis to the bone. There is Paget disease of the bone. There will be some form of remodeling that takes place, which will cause elevation of this marker. And people with cholestatic form of liver pathology, there's a metastasis from the colon, occluding, the biliary tract in the liver. They can have elevated alkaline phosphatase. They are canalicular products. So alkaline phosphatase is usually very much elevated in cholestatic form of hepatic, injury or jaundice. So how you are going to know that, okay, this is likely to be cholestatic is when you now compare it with the level of GGT, which is a gamma glutamine transaminase level, transferase. So gamma glutamine transferase level would also be elevated if it is due to a cholestatic disease of the liver. So you check your LFT and you check your GGT. So if they are normal, then you can say that, okay, it's likely to be from the bone, or maybe there's a tumor like a seminoma somewhere that is producing this guy. So seminoma produces because they have some embryonic remnants that have pluripotent potential to produce some enzymes or some products that can be produced from the placenta, like alkaline phosphatase. So the next is alpha fetoprotein. Alpha fetoprotein, I know we have come across this a lot of time. So most of the time it's elaborated from individuals with hepatocellular carcinoma. So it's one of those markers you can use to monitor hepatocellular carcinoma. Alpha fetoprotein is elevated in them. People with some non-seminomatous malignancy like a yolk sac tumor. So from the yolk sac, you have production of AFP2. So people with endodermal sinus tumor or yolk sac tumor usually have elevated alpha fetoprotein. People with some mixed germ cell tumor, meaning that probably they have an endodermal sinus tumor mixed with seminoma or yolk sac tumor mixed with embryonal carcinoma and the likes. So once you have something that's secreting AFP there, there's going to be elevation of the AFP. So for whatever reason, in ataxia telangiectasia, it is also elevated. So we don't really know why, but it's elevated too in people with ataxia telangiectasia. People with neural tube defect usually have elevation of alpha fetoprotein. Please, can we hear me? Is it stuff from my own side?
Yes.
Sorry,
Okay.
sir.
Somebody is
It was what?
Sorry, sir. Please, can you change the color of this your marker? We are not seeing clearly. It's dark. So once you maybe you change
Oh,
it to yellow or something.
sorry,
Yes, I see
sorry.
clearly. Thank you.
I think yellow is better.
Yes.
So
Yes.
sorry about that. So people with
Yeah.
hepatocellular carcinoma, people with yolk sac tumor, um, people with mixed form, all of them, and people with ataxia, telangiectasia, they can have elevated AFP. Placenta abruption can cause elevated AFP. Fetal death can cause elevated AFP. Multiple gestation can cause elevated AFP because it is produced by the fetus. So, and it is transiently elevated in pregnancy. So, if you have multiple fetus, there could be elevation of the AFP. Somebody has liver cancer, they can have it. Yolk sac tumor, they can have it. Neural tube defect, it can leak through the neural tube defect into the amniotic fluid and from there even into the maternal circulation, and you have elevation of AFP. Also, there's something I did not mention. Okay, it's here. Abdominal wall defect is also associated with elevated AFP. So I know that Guggenheim will have mentioned this during GI section. So people with gastroschisis, people with omphalocele, they can have, AFP being elevated in them. But the only condition that drops AFP level is Down syndrome and the other trisomy. So trisomy 21, 18, and 13. Alpha fetoprotein is reduced, but it is increased in from the fetus who are producing due to multiple gestation, neural tube defect, abdominal wall defect, hepatocellular carcinoma, yolk sac tumor producing AFP. All of them would cause elevation of AFP as well as ataxia, telangiectasia. So you just have to be familiar with all these things. You don't necessarily need to cram them. HCG. So HCG2 can be elevated in some form of testicular cancer, particularly choriocarcinoma of the testes can cause elevation of HCG. Normal choriocarcinomas of the placenta too can cause elevation of HCG, as well as people with idateform. So idateform molar pregnancy, choriocarcinomas, testicular cancer, that is from the choriocarcinoma type, can cause elevation of HCG. And also people with the mixed germ tumor just involving choriocarcinoma of the testes too can have elevation of the HCG. Don't forget it's produced by the cystotrophoblast of the placenta. So the CA15 and the CA27 are, associated with breast cancer. So CA15, 27, 29, breast cancer. Just no 15, breast cancer. 19, 9. So 19.9 is pancreatic adenocarcinoma. 19.9 pancreatic adenocarcinoma. 19.9 pancreatic adenocarcinoma. CA125 is ovarian until otherwise proven. It is an epithelial ovarian cancer until otherwise proven. CA125 is ovarian. 19 is pancreatic. 15, 27, 29 is breast. Calcitonin, we know this already. Amen. Medullary thyrocarcinoma is calcitonin. What else is also peculiar to calcitonin? What type of protein is calcitonin? Anybody? If it becomes too much, what can it cause? Anybody remember? People are saying so many things, but somebody has gotten the answer. Only one person has gotten the answer. Because I heard something. Amyloidosis. Calcitonin can cause localized amyloidosis. So we don't want to have too much calcitonin deposit because of amyloidosis. So what are the other types of localized amyloidosis? Anybody remembers? DM, yes. What else? AMP, fantastic. And what would the AMP cause? If yes, there's AMP is produced from the atrium. So if you have abnormal accumulation of AMP in the atrium, atrial fibrillation, that's it. DM, Alzheimer's disease, calcitonin, that's localized, and you have the systemic form, the AL type, the AA type, the transthyretin, and the what? What's the last one?
Beta 2
beta 2
microglobulin.
Microglobulin.
So CA, colorectal cancer and pancreatic cancer. Just remember gastric cancer generally, like GIT cancers generally are shared with CA, carcinoembryonic antigen, colorectal, pancreatic, gastric. What other what mutation do we say is associated with both colorectal and pancreatic? What mutation? Yeah, mutation is what gene can be mutated that's going to cause both pancreatic and colorectal? Anybody know?
KRAS.
DCP.
DPC. DPC.
DPC.
DPC. So the DPC4, the SMART4 or the DPC4, deleted in colorectal cancer, deleted in pancreatic cancer. So deleted in pancreatic cancer is DPC4, which is also known as SMART4, and both of them can cause colorectal and pancreatic cancer. Chromogranin. So chromogranin is a tumor marker that is present in neuroendocrine tumors. So you have a lot of neuroendocrine tumors. There are a lot. Neuroendocrine tumors are just from neuroendocrine cells, and these are cells that have like neural functions, and sometimes they have hormonal endocrine functions in which they secrete some peptides. For example, small cell carcinoma of the lung. Anybody knows the two peptides that come from small cell carcinoma of the lungs? Typically.
Chromogranin.
No. I'm not asking
PTH, parathyroid related peptide.
No. Small cell.
What's
Small cell.
Huh?
Small
For
cell.
small cell.
Neurospecific analysis.
No.
Please, what's the question?
Carcinoid tumor.
No. Dr. Abande must have emphasized.
What's the
Dr.
question
Abande
again,
must not
please?
hear this question I'm asking.
What's the question
Is
again?
this syndrome of inappropriate?
Please, can you repeat the question?
So what are the peptides that can be elaborated? Paraneoplastic peptide that can be elaborated from
ACTH and
It's
SIAD.
exactly.
Neurology and
ACTH or SIAD.
Why are people saying ADH and ACTH? ADH and ACTH, the A's of small cell carcinoma of the lung. So if you see somebody having elaboration of ADH, maybe just like syndrome of inappropriate years, you are correct. And also somebody having increased ACTH, think about small cell carcinoma of the lung. Which one will express parathyroid hormone related peptide?
Renal cell carcinoma.
That's the squamous cell carcinoma.
Yes, renal cell can also do, but the number one that we must always remember is squamous cell carcinoma of the lungs. Renal cell carcinoma too can do it, but the commonest is squamous cell carcinoma of the lungs. So the one there that is a neuroendocrine tumor there is small cell carcinoma of the lungs. Carcinoma tumor is another neuroendocrine tumor because it can elaborate serotonin, histamine, and all those things. Neuroblastoma is another one. There's a lot of them. You know, pancreatic tumors like insulinoma, glucagonoma. Who knows what's the acronym for glucagonoma? What's the peculiarity? Like glucagonoma, what do you remember? Do you remember the features of glucagonoma?
They have this
Dermatitis,
necrosis, this dermatitis, migratory,
D's.
necrotic
The D's.
EBD.
Nobody said the
Yeah,
D's.
this
Nobody
the
mentioned the
D's,
D's.
the sick D's.
dermatitis.
The D's of glucagonoma. We have to revise all these things. Very important. You have to know all those things with you. It has to be with you. The D's of glucagonoma, diabetes, DVT, dementia, somebody talking about the rash, diarrhea, and all those things.
Depression.
Depression. Yes, the D's. So, chromogranin, neurospecific enolase, what's it called? What's it called? Tumor markers that is present from neuroendocrine tumors. Chromogranin, neurospecific enolase. And I've given an example: small cell carcinoma of the lungs, carcinoid, neuroblastoma, insulinoma, glucagonoma, all of them, they are neuroendocrine tumors. LDH is very much present in testicular germ cell tumors, particularly the non-seminomatous type. So this is not the time to be picking seminoma. The only one that seminoma release is what? What is it?
Prostatitis.
Yeah,
Alpha
PLAB,
fetocystine.
PLAB,
Fab.
PLAB. So, ovarian dysgeminoma, testicular germ cell tumors can produce LDH. So LDH is just due to high tumor burden because LDH is produced when there's lysis of cells. LDH is released when there's cell lysis. So high tumor burden, high LDH level, very common in ovarian dysgeminoma and testicular germ cell tumor that has a non-seminomatous type. So the PSA is specific to prostate cancer, which we have talked about. It is a marker for recurrence after treatment, you know, so it's questionable for the screening. So they are still debating if it's needed or not. So it can be elevated in other things too that is not related to prostate cancer. Even simple prostate massage can elevate PSA. People with PSA, BPH can have elevated PSA. People with prostatitis can have it. So moving on to the histochemical stains, they are just similar to the marker in a way. Chromogranin and synaptophysin. So now, you can use this stain to identify the primary site of a metastatic tumor. Maybe you see a tumor somewhere and you don't know where it's coming from. So you can obtain a sample, you can stain it, and look for some stain that it picks up so that you can identify where it's coming from. And it's very useful to classify tumors that are difficult uh, to identify. So it has prognostic and predictive value. So chromogranin and synaptophysin. So any tumor that picks up chromogranin and synaptophysin, you know it's from a neuroendocrine, cell. So which includes the small cell carcinoma, the small cell carcinoma of the lungs, the carcinous tumor, as well as the neuroblastoma. Cytokeratin from the word cyto cell, keratin, epithelium, lining. So epithelial cells take up cytokeratin state. So which includes epithelial cell tumor like small cell carcinoma of the skin. Desmin means muscle. So the only cells that are going to pick up desmin stain are the muscle cells. So the muscle tumors like rhabdomyosarcoma, 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 rhabdomyosarcoma butyroides. Anybody familiar with that? Sarcoma butyroides. Are we familiar with it?
Yeah, clear cell. Sorry.
So if they give us a case
Vagina.
study and they say
Stain
that
on the vagina.
the what?
Vaginal lesion.
Yeah, so
Yeah,
and they tell us
vagina.
that there's a polypoid mass projecting from the vagina of a 2-year-old baby. You are going to be thinking of saccharoid butyroides. It is a form of, muscle tumor, and it is going to stain positive for this. They can ask you your exam. The next question will be like, what is it going to stain positive for? If you don't know the diagnosis, there's no way you know what it's going to take. So that's desmin. I can't remember how the session went. Maybe repro or something, but it's somewhere in our first state. Clear fibrillary acidic protein. So just anything that is from the neuroglia will stain positive for clear fibrillary acidic protein. So the neuroglia components include astrocytes, the Schwann cells, the oligodendrocytes, all of them. Tumors involving all these things are going to pick up the clear fibrillary acidic protein. Neurofilament is straightforward. Any tumor from the neurons, like a neuroblastoma, is going to pick up neurofilament stain. PSA, prostatic cancer, PECAM. So when we are talking about PECAM, then I think I gave us like a code. Like we said, all the camps are from where? All the camps are from where? The what?
Endothelial cells,
Yeah,
blood vessels.
then the endothelial cells vessels. So vascular tumors like angiosarcoma. Angiosarcoma, they will stain positive for PECAM. So S100 is very important. You cannot forget S100. So I put it here, men like S100. So the men like S100. The men standing for melanoma. The like standing for the Langerhans cell histocytosis. Then the S100. So schwannomas too. The S, schwannomas, Langerhans cell, melanoma. All of them, they are derived from the neural cells. Hope we know the way somebody that has Langerhans cell histocytosis is going to present.
They'll have lytic lesions. They may present with recurrent otitis media, leading to mastoiditis.
Yes. Tennis racket or
Brevis granules, brackets,
very good.
shape,
So that's very good. So
electron microscopy.
trap, tartaric resident acid phosphatic.
Yes.
Tartaric resistant acid phosphatic for hairy cell leukemia. Hairy cell leukemia. You can't go to the exam, you don't know hairy cell leukemia. Pancytopenia and what? Pancytopenia and what?
Massive splenomegaly.
Fantastic job. Massive splenomegaly and pancytopenia. So vermectin, mesenchymal tissues like fibroblasts, the endothelial cells, and the macrophages. So vermectin is just mesenchymal, any mesenchymal tumors, sarcomas, and the like. So don't really worry yourself about, but just know mesenchymal tumors, like sarcomas and other tumors like endometrial and meningioma. So from the word, I think I
It
remember I
says
put it here.
people want to join the class. People are waiting outside to join the class.
People are waiting outside. Okay, so I think we need to continue. So remember. Hello.
I've messaged him.
Okay, thank you so much. So vermectin, remember vermectin, remember renal cell, remember vermectin, renal cell cancer RE. Remember hem for the meningioma. Yeah. So RE, remember renal cell and hem for the meningioma. Then the other ones for the mesenchyma, because normally the initial stuff is once you see vermectin, think about mesenchymal tissues like sarcoma, mesenchymal tumors. Then the other ones include you remember, which is RE for renal cell and hem for the meningioma. So I just put something there just to help us recollect. Then the next stuff here that we have, let me see, I think we have a question somewhere here. A 41-year-old man with HIV comes to the physician because of rectal bleeding and itching for 2 weeks. During this period, he has also had pain with defecation. 4 months ago, he was diagnosed with anogenital warts that was treated with cryotherapy. Over the past year, he has been sexually active with 3 male partners. They use condom inconsistently. Current medication includes this. Digital rectal examination and endoscopy shows exophytic mass in the anal margin that protrudes into the anal canal. The mass is tender to palpation and bleeds easily with contact. Lab shows leukocyte count of this. CD4 count of 410. A biopsy of the lesion shows a well-differentiated squamous cell carcinoma, which of following cellular process are most likely involved in the pathogenesis of this patient's malignancy.
Yes.
Inactivation
of P53.
Good job. What's our diagnosis?
HPV.
Anal cancer.
Anal cancer from
HPV.
HPV.
And how does it work? How does it, go through the process of oncogenesis? Like, what does it do? The HPV.
E6 inhibit, P56, E7 inhibit.
E6 and E7. So what does E6 inhibit?
TP53.
Yeah, then E7 inhibit.
E7 for RB.
Right. Okay. That's good job. So moving on to P glycoprotein. So P glycoprotein is just an ATP dependent. It is an ATP dependent. Which other process have we talked about in pathology that is ATP dependent?
So can I ask a question in the last question that we did? Are we going through that process of adenocarcinoma where P53 is the carcinoma? Why, I'm wondering why we chose KRAS. I know it's
No, we didn't choose KRAS. We chose inactivation of P53.
Oh, okay. I thought they chose KRAS. Okay. Yeah, that's what I chose too. Okay.
Yeah.
Thank you.
You're welcome. So, anybody knows ATP dependent process in pathology that we have said?
Apoptosis.
Apoptosis. Very good. So, ATP dependent efflux pump is a P glycoprotein. It is also known as MDR protein 1. So we have to keep that in mind. Multi-drug resistance protein 1 or P-glycoprotein, they mean the same thing. And what do? Just one simple task. They pump out chemotherapy agent that is delivered to a cancer. They will pump it out so that the chemotherapy agent doesn't work. So it's a means of cancer being resistant to treatment. It's as simple as that. So let's see this. A 78-year-old man receives chemotherapy for advanced hepatocellular carcinoma. Despite appropriate therapy, he dies 4 months later. Histological examination of the cancer shows the presence of a transmembrane efflux pump protein that is known to cause decreased intracellular concentration of chemotherapy drugs. Which of the following best describe this membrane protein? So it is P-glycoprotein. You can see a question as simple as that. So moving on to paraneoplastic syndromes. So the first here is dermatomyositis, and we know the way it's going to present from our knowledge of musculoskeletal. So they are going to have a progressive proximal muscle weakness, in addition to some lesions like Gutron papules in their fingers and elytroph rash in their face. Hope we know all this, the way this lesion presents.
Yes.
Yes, yes.
Yes.
Thank God.
Electric wash.
So elytroph rash and the Gutron papules in the back of the finger. So what you want to rule out is next is what? Ovarian adenocarcinoma, because it's likely to be an ovarian adeno. Don't forget, that's the next thing you are looking for in the question. Is there ovarian carcinoma there? Yes. So all the paraneoplastic syndromes are divided into cutaneous, musculoskeletal, endocrine, blah blah. They are very simple. So that's dermatomyositis. The next one is acanthosis nigricans. So we have talked about this in dermatology, right? Hyperpigmented
Yes.
velvety plaques in the axilla and the neck, intratuginous areas. Just go and rule out gastric adenocarcinoma or any visceral malignant. So if you don't see gastric there and you see pancreatic, are you going to pick it? True or false?
True.
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 No catch.
True.
Any other visceral malignancy. So there's a triad sign, multiple seborrheic keratosis. They're just plenty. Just rule out a gastric adenocarcinoma, jejely. Hypertrophic osteodystrophy. So that's more like, hypertrophic osteoarthropathy. That's more like sorry, I'm not showing this lesion so that we know them. Abi, is there anybody that wants to see this lesion? I think we all know all these lesions, right? Yeah.
Yeah.
So
Can you show
You
laser
see,
Katrina again?
let me do. I don't want to assume. So which one do we want to show now?
Laser trend.
Multiple
yeah.
seborrheic dermatitis. Seborrheic
Hello,
keratosis.
Doc.
Yeah, I'm listening.
Yeah, you see, most of us joined at various times. It's not everybody that started at the same time. So some people didn't do the dermatology with you. So it will be nice if you are like showing these things again. For those who have done with you, it will be repetition. But for like those of us who are new, it will really help us. Thank you.
Thank you for speaking. So I didn't know that. I'm so sorry. So this is seborrheic keratosis. Can we see this lesion? Just see them. Once you see something like this in somebody's back, seborrheic keratosis. Let me see. So this is a single lesion for seborrheic keratosis. Just see the uncyst. What's the word that we use to describe the appearance? Anybody remembers the word?
Stock-on
Yeah.
appearance.
As if it was tagged to the skin. So once you see this is a seborrheic keratosis. So, when it becomes multiple at the same time, you have to rule out a malignancy because that is likely to be a paraneoplastic phenomenon. You see, that statement that it is a paraneoplastic phenomenon can even be tested. You just describe a situation of somebody having finger clubbing or something, or maybe somebody having what's it called? Somebody having this seborrheic keratosis or having acanthosis nigricans, and they will tell you that the person has weight loss, early satiety, and the likes, and abdominal mass, and the next thing is what is responsible for this, So you just say paraneoplastic phenomenon, and you go and pick it. It's as simple as that.
Yeah.
Yeah,
Thank you.
you are welcome. So, then, let me show acanthosis nigricans. Acanthosis nigricans. Acanthosis nigricans. So just see this black barbecue lesion in the neck. Once you see this in the groin, in the axilla, this black barbecue lesion, this is consistent with acanthosis nigricans. Once you see this, just go and rule out, is this person having insulin resistance, right? Maybe diabetes, obesity, PCOS. Hope you remember. Or the person has a tumor of the GI. So those are the two things that can cause acanthosis nigricans. GI tumor or anything that can elevate insulin, due to insulin resistance. So when you watch the dermatology video, all those things will become clearer. Dermatomyositis, the Gutron, the dermatomyositis, just see what, yeah. So this is erythroid rash in the face. This is a Gutron papus, or what they call the mechanic fingers, right? You see the
Yes.
plaques at
Yeah.
the back of the extensor surface of the fingers. Once you see this spot, it is spot diagnosis. You don't have to even waste time. You pick your answer confidently and you move. So hypertrophic osteoarthropathy is just like finger clubbing. Finger clubbing, arthralgia, joint effusion, and peristalsis of the tubular bones is in keeping with people with adenocarcinoma of the lungs usually, most of the time. Then moving on to the endocrine hypercalcemia. So what do they release? PTH releasing peptide. Please don't go and pick PTH. We have to pick PTH related peptide. Very important stuff. So people with squamous cell carcinoma of the lungs, usually squamous cell carcinoma of the head and neck, renal, bladder, breast, ovarian, they can produce it. So just change it to squamous cell of any type. But most of the time, it's usually that of the lungs. They will elaborate this guy, and there's going to be hypercalcemia. So you see somebody having calcium of 14, because if it's from malignancy, your calcium is not even going to be 11 or 12. It's going to be like 14. And if you check your PTH level, it's going to be less than 10, because it's not coming from the PTH. So you know that the next thing is like, probably there's a PTH related peptide that's actually causing this hypercalcemia. Some people will just become destabilized immediately that why is PTH less? Why is it very low and there's high calcium? So it actually tells you that there's something else that is provoking that calcium release, which is PTH related peptide. So people can also have hypercalcemia due to elaboration of vitamin D, paraneoplastic production of vitamin D, 125 cholecalciferol, 125 vitamin D3, which you know as calcitrol. Calcitrol. It's the only malignancy that causes it is lymphoma. Many people don't know this. I'm telling you now. Let us put it at the back of our mind. Lymphoma produce 125 vitamin D3 that can cause hypercalcemia. So part of still on the endocrine, don't want to forget Cushing syndrome and SIDH. So because Cushing syndrome, you can have elaboration of ACTH. For SIDH, you can have elaboration of ADH. And both of them comes from small cell carcinoma of the lungs, just like we have mentioned previously. So, and in the SIDH, you are going to see features of what's it called? Hyponatremia. So people with SIADH from small cell carcinoma of the lungs, they are going to be having hypervolemic hyponatremia. True or false?
No, euvolemic.
Euvolemic.
Euvolemic hyponatremia.
So they are going to be having euvolemic hyponatremia. So this is something you have to pay attention to in your exam. So euvolemic hyponatremia, in syndrome of inappropriate secretion of ADH.
Moving on to the the hematologic. So polycythemia, erythropoietin is the cause. Erythropoietin is what is being elaborated. A lot of them, the pheochromocytoma, the renal cell carcinoma, the hemangioblastoma. What is common to these three that I've highlighted? Pheochromocytoma, renal cell carcinoma, hemangioblastoma. Anybody?
They have a common
There's
VHL.
increase in
VHL in love.
VHL, VHL, we get it.
Yeah.
We get it. VHL. Yes. So hepatocellular carcinoma too, can elaborate erythropoietin. Some fibroids too can elaborate erythropoietin. So we also have poor red cell aplasia, which is anemia with low reticulocytes. If there's anemia, you expect, okay, maybe, for example, in situation of hemolytic anemia, you expect your reticulocyte to start proliferating to compensate for that loss of red cells. But if you're having anemia with low retics, and you're thinking of a malignancy, blah, blah, so it's likely going to be from a thymoma. Because it's pure red cell aplasia. Another thing that can cause pure red cell aplasia is erythropoietin treatment. We give somebody too much dose of erythropoietin, they can have what's it called? Pure red cell aplasia. So good syndrome can cause hypogammaglobulinemia. So you just good syndrome is associated with hypogammaglobulinemia, and it's also from a thymoma. And what is peculiar to good syndrome is that there is hypogammaglobulinemia, that is, the B cells are no longer producing immunoglobulins. You also notice that the CD4 cells count too also reduces, and they are predisposed to recurrent infections. That's good syndrome. So hypogammaglobulinemia with thymoma is good syndrome. Anemia with low retics and thymoma is pure red cell aplasia. True cell syndrome is very commonly tested, and they present with migratory superficial thrombophlebitis. So you just seeing the question stem that the patient is presenting with pain, swelling, erythematous lesions in the legs or the lower body, which is changing from one part to another part. Most of the time, it is consistent with pancreatic adenocarcinoma. You can't forget it. Once we are seeing features of Trousseau syndrome, migratory superficial thrombophlebitis, think of pancreatic adenocarcinoma as a cause. Pancreatic adenocarcinoma. So one risk factor for pancreatic adenocarcinoma that we mentioned today, anybody knows?
Smoking.
Smoking. That smoking can also cause which other cancer? That is
Bladder cancer.
Bladder cancer. What else? That is not common knowledge. Renal cell carcinoma. Renal cell carcinoma. Renal cell carcinoma. So that's that about the pancreatic adenocarcinoma, and they can also, form the non-bacterial thrombotic endocarditis. The non-bacterial thrombotic endocarditis. That's very closely related to the Liebman-Sack endocarditis. I know Dr. Babande will have said that. Do you remember anything about this non-bacterial thrombotic endocarditis?
Seen in SLE.
Is mostly bilateral.
Yeah,
Affecting the
SLE.
tricuspid valve.
And you notice that
Pancreatic adenocarcinoma.
they are sterile. If you try to culture them, you won't grow anything. They are sterile.
Right.
Platelet
Yeah.
vegetation on the heart valve. And the peculiarity of these guys, why they are dangerous, is that they have a very high tendency to dislodge and embolize. So if you see anybody with non-bacterial thrombotic endocarditis from pancreatic CA or from SLE, you anticoagulate immediately, because the person has a very high chance of throwing that clot. So the pancreatic adenocarcinoma can, develop Trousseau syndrome from paraneoplastic stuff, and also non-bacterial thrombotic endocarditis, because it is an hypercoagulable condition. That's one thing about this pancreatic adenocarcinoma. So studies have shown that maybe the excessive mucin that's produced and the likes, and inflammation causes all these things, leading to these features. So moving on to the neuromuscular. So this is where it gets a little bit complex, but still simple. The first one is the anti-NMDA receptor encephalitis. Look at the word encephalitis. Encephalitis. Anti-NMDA receptor encephalitis. So that means that most of the problems that this patient is going to be presenting with is going to be related to the brain. And you need to know that it is related to ovarian teratoma. So rule out ovarian teratoma in an individual with NMDA receptor encephalitis. Which ovarian cancer do we rule out in dermatomyositis?
Ovarian.
Ovarian
Adenocarcinoma.
Ovarian adenocarcinoma.
Adenocarcinoma, yeah.
In anti-NMDA encephalitis, you are ruling out ovarian teratoma. The difference.
Teratoma.
So how will the patient present? They have cognitive issues. They cannot think. Memory problems. They cannot talk. Language dysfunction. Memory issues because we are dealing with an encephalitis. Then what is going to increase your suspicion is that it will be coupled to psychiatric manifestations. So the person start having psychosis, all those depression, mania, blah, blah, with problems with memory, thinking, language, speaking, having seizures, dyskinesia, just this is likely to be an autonomic, paraneoplastic manifestation of a tumor due to production of antibodies from that tumor against NMDA receptor. Very important. The next is opsoclonus myoclonus ataxia syndrome. Very simple. Once you see this in a child, your diagnosis is neuroblastoma until otherwise proven. If you see this in an adult, your diagnosis is small cell carcinoma of the lungs until otherwise proven. So dancing eyes, dancing feet. So what we are just saying here essentially is that they will tell you that the patient is going to be having features of opsoclonus in which the eyes are just going to be looking at different direction at different times, more like a saccadic movement, looking here, looking there, looking, and you also notice that the limbs are going to be jacking involuntarily. So that's the myoclonus aspect. So the patient is going to be having myoclonus, they are going to be opsoclonus, and the gait is going to be like white base, as if the person is drunk. So once you are seeing white base gait, ataxia, rapid involuntary movement of the eyes and the limbs, that is neuroblastoma in a child until otherwise proven. In an adult, it's likely to come from small cell carcinoma of the lungs. Very important. So we should not go and pick neuroblastoma in somebody that is aged 30 years. So we have to look at the age first and not rush to pick neuroblastoma. So next is paraneoplastic cerebral degeneration. So just name any cerebral symptom that you can think of. So this patient might have vertigo, might have dysarthria, difficulty in speaking, difficulty in what's it called, movement to balance, ataxia, dysphagia. They can have tremor. What type of tremor do they have? Cerebral lesion.
Intention tremor.
Intention tremor.
No, that pause is a little bit scary. Is it that people do not hear my question?
We were trying to differentiate it.
We're putting.
Please, don't forget. Don't forget. I know it's a lot of information. Yeah. So
and we need to unmute before we
oh
speak.
yeah, that's another thing. So intention tremor, cerebral lesion, dysdiadokinesia, dysmetria. They are not finding it difficult to judge distance. So instead of them to put their leg there, they will be putting their leg in another place because they cannot judge that distance. So dysmetria, intention tremor, hypotonia, this atria, all those things, very common to cerebral lesion. So, and once you are seeing that, and the person has a cancer, so you have to look, okay, what cancer is it likely to be? So the way to look at it is that we have different cancer that produce antibody against different antigens of the Purkinje cells of the cerebellum. What is peculiar to the Purkinje cells of the cerebellum? Anybody remembers? Pathology.
It's one of the parts of the brain that can get affected by ischemic injury.
So the neurocortex 356, the Purkinje cells of the cerebellum, as well as the pyramidal cells of the what?
Hippocampus.
Hippocampus. So those are
Hippocampus.
the three areas that can suffer ischemic injury. Very important stuff. You don't want to forget that. So, the what are these cancers that we are talking about? So, number one, anti-U. So anti-U, 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 you got is more like milk. So milk comes from the breast. So people with breast cancer and other gynecology cancer. So this patient having endometrial cancer, ovarian cancer, breast cancer, they all produce anti-U, that can lead to this. If the person is having a small cell cancer, it's going to be anti-HU, HU. Everything about small cell cancer causing all this problem is usually anti-HU. In fact, it is due to antibody HU that small cell cancer is causing. Okay, I'm going to mention it later. So anti-HU is always from small cell cancer. Anti-U is from the breast cancer and other gynecology cancer. Anti-TR is from Hodgkin lymphoma. So these three cancers can cause neoplastic cerebellar degeneration. So let's keep that in mind. Then there is paraneoplastic encephalomyelitis. So this patient is having paraneoplastic encephalitis with a paraneoplastic myelitis. Now, what we are just going to notice is that we are going to be seeing features of encephalitis, which is the seizures, the memory problems, the language dysfunction. In addition to that, there's going to be weakness of the lower extremities and sensory abnormalities. So you know that the spinal cord is involved. So paraplegia, sensory loss in the legs, with all these things, memory, seizures, that there's a coupled effect, encephalomyelitis. So it is due to anti-HU of small cell carcinoma of the lungs. The next is Lambert-Eaton myasthenic syndrome. We know this from our neurology. It is due to antibody against the presynaptic P antitype calcium channel. You don't want to forget that. And it is related to small cell carcinoma of the lungs. I don't know if how somebody will not know this and go for step one. It is impossible. It has to be like with you. Small cell carcinoma of the lungs can have antibodies against P and the Q type calcium channels, leading to Lambert-Eaton syndrome. And we know the difference between Lambert-Eaton syndrome and MJ, right? I know we know all these things.
Mhm.
Yes.
Yes.
So myasthenia gravis, it's also a paraneoplastic manifestation of a thymoma. Just like thymoma can cause Good syndrome, thymoma can cause what else again? What do you call this thing? I forgot it myself. Pure red cells.
The pure cell. Pure red cell.
Yeah. So thymoma can also cause myasthenia gravis. So it's due to antibodies against the postsynaptic ACH receptor. So the Lambert-Eaton is due to antibody against the presynaptic calcium channel. So don't confuse them. So like thymic aplasia or thymoma is usually shared with myasthenia gravis. Then we're rounding up by talking about the let me see if we have any question. Have any questions? Okay, I wasn't able to get any question, but we have loads of questions.
Did you say thymic hypo or hyperplasia?
Hyper.
Thank you.
Normal aging. So this is just a time-dependent progressive decline in organ function. With age, everything will start getting weak. And what are the three molecular changes that are responsible for aging? So the first one is genetic, which is what? Telomere shortening. Well, we have talked about that. So with each replication, you are having shortening of the telomere. That's the way it should be naturally. Except there's not a malignant transformation where you have expression of telomerase, which tries to now prolong that telomere, preventing the cells from undergoing apoptosis. But with normal age, as we are replicating the cell, the telomere will be shortened, and later it will be labeled for apoptosis and it's going to, be killed off. There's also epigenetic modification. like DNA methylation. And if you remember from our biochemistry, if you methylate a sequence of DNA, what happens to that DNA sequence?
It's
It's muted.
Muted.
So it
Silent.
becomes
Silent.
it becomes muted, and at the end of the day, the protein that it goes for will not be expressed. You could be protein for collagen, for elastin, or something. It's not going to be expressed, and that cell is going to die at the end. The metabolic activity is also dropped, like mitochondrial dysfunction. So no energy again. That's why old people, they are weak, because the mitochondrion at each of the cellular level is reduced due to mitochondrial reduction. So all these things work together to cause all this abnormality that we're going to be talking about shortly. So the first is, what is a cardiovascular manifestation of aging? Number one, there's going to be a drop in the arterial compliance. What are we talking about? We say that the arterial compliance is reduced. Now, if there is telomere shortening, if there's DNA methylation, there's no protein. If there's no protein, protein is the basic constituent for elastin and collagen. And we know that the arteries, particularly the aorta, is rich in elastin, right? If we take out the elastic fibers in the aorta, do we think that the aorta is able to stretch when blood comes in?
No.
No. So that means
No.
that the compliance of the artery is going to drop, and it's going to become stiffer because it cannot stretch. So that's why it makes sense for us to say they can put it arrow question, which of following will be the cardiovascular changes in the artery with aging. Arrow question: stiffness up and down, compliance up and down. So you have to be able to interpret them individually. So compliance drops because it cannot stretch. It becomes stiffer because the elastic fibers gives it the elasticity, reducing the stiffness. Now, what is going to happen to the diameter? The aortic diameter is going to increase because it's going to have ability to hold on to more blood. Because now, like, if just imagine that you have this initially, and it is very thick. It is very thick because you have your collagen. But if you lose your collagen and the what's it called? Where's the cleaner now? Because the barbarian is the one that knows how to use all this marker. Me, I don't. So, yeah. So, I don't know if you're going to. Oh, it's not going to wipe. Okay, so my point is, it's somewhere here. Hmm. This is eraser or something. There used to be an eraser somewhere. Okay, let's just ignore that. But the point is, if this is initial vessel and you lose the elastic fibers, the collagen fiber, this is going to become wider, right? So that means that there's going to be an increased capacity. So the aortic diameter will widen, right? Does it make sense to say that?
Yes.
The aortic diameter will widen. And the left ventricular cavity side is going to reduce because the left ventricle will be finding it very difficult to pump blood into the aorta, because normally what the aorta should do in response to preload delivery to the aorta should be that the aorta stretches, becomes compliant so that it can accommodate that volume. But when the left ventricle is contracting, the aorta is not compliant enough to accept that volume. So the left ventricle has to undergo some form of remodeling, like hypertrophy, and in the process, it's going to undergo hypertrophy, and the cavity size is going to reduce, and it's going to take the shape of a sigmoid shape due to myocardial hypertrophy. So it's going to appear like a sigmoid, shape because of reduced cavity size from the hypertrophy. Now, most of the volume of fluid retained within the left ventricle is going to be passed off, proximally to the left atrium. So that's going to increase left atrial cavity size. So that's more like volume overload. So the left atrial walls are going to be thinner and larger. So in order to accommodate the volume that's coming back to them, but that of the left ventricle is going to undergo more like a concentric hypertrophy. So, and that is not going to increase the cavity size, it's going to reduce the cavity size. Why the eccentric hypertrophy increase cavity size? I don't know if I'm making sense or I'm causing confusion.
You're making sense.
So if the left ventricle is finding it very difficult to pump, that's more like a pressure resistance. So it's going to undergo a concentric hypertrophy. And concentric hypertrophy means that the cell fibers are arranged in parallel. So they become narrow. The cavity of the left ventricle becomes narrow at the end of smaller at the end of the day. But some of the fluid that is retained in this left ventricle too, because it cannot be pumped, will be moved proximally to the atrium. So atrium will just be taking a lot of volume because atrium is not the one contracting. So there's no pressure from afterload resistance. There's no pressure. The only thing that is overloading that left atrium is just fluid volume. So it's going to undergo eccentric hypertrophy and it's going to become bigger inside. So you have to pay attention to that caveat. Then with aging, because of the microtrauma to the valves, the aortic valve, the mitral valve, constant opening and closing, they can have some calcification. What type of classification would that be? Anybody?
Dystrophic?
Dystrophic calcification. Good job. And because of the degeneration of the sinoatrial node, the maximal heart rate is going to reduce. So that's why sinus pulse, sinus arrest, they are shared with aging. Hope we know that. So the older somebody is,
Yes.
the higher the risk factor of developing, sinus arrest and all those pulse and the likes. So
Mm-hmm.
that's not about the CVS complications. For the gastrointestinal, the first thing is you look at it from the esophagus to the stomach to the colon. Esophagus, stomach, colon. Esophagus, stomach, colon. So what will happen at the level of the esophagus? The lower esophageal tone, the lower esophageal sphincteric tone is going to reduce. The reason is because of reduction in neural response and neural activity. So the sphincteric action is compromised and you tend to have constant reflux into the esophagus. Because of the fact that with age, the blood supply to the gastric mucosa is going to drop, the regenerative ability of the gastric mucosa cell is going to be exhausted. So the gastric protection, the gastric mucosa protection is going to be dropped. So that means that they can highly be predisposed to developing gastric ulcer. And because of the little neural activity in the colon too, from the mitochondrial dysfunction and the DNA methylation, colonic motility is also going to drop, so they can be constipated. So that's why one of the common problems in old people is what? Constipation. They are constipated. I hope we know that they present with constipation more, right?
Yes.
So they are
Yes.
constipated, they have, GERD, they can develop ulcer. The next is hematopoietic stuff. So this one is self-explanatory. Just telomere shortening, you are losing all those cells. The bone marrow cells are part of the labile cells that are always proliferating. They start reducing. So little bone marrow mass, the white blood cells, the red blood cells, they are dropping. That's why they get anemic. That's why they are predisposed to infection quickly. That's why they can easily bleed, and that mass is replaced by fat, and they find it very difficult to respond to stressors. So they have early little accident, blood loss, they can even die because of poor response to that. Immune. So now, the pre-immunal problem here is effect on the adaptive immunity. So what are we talking about? So we have to pay careful attention here. With aging, you have a reduction in the naive B cells and T cells because the naive B cells and T cells needs to be replaced constantly. Now, don't forget, there's a reduction in the bone marrow mass. So there's no way the naive B cells and T cells can be replaced. The only one that is preserved is the memory B cells. So those ones that they have been formed already, they will stay there. They live long, so they will stay there and they will not cause any problem. So that brings us to the problem of immunosenescence that happens with aging. What immunosenescence is telling us is that because of the fact that they don't have they have little naive B cells on the T cells, it means that they cannot respond to a new infection and they cannot respond to vaccine. But if an infection that they have been exposed to before comes in again, they can attack it because their memory B cells and T cells are preserved. If we give somebody a vaccine, do we need the memory B cells or T cells to respond to it? Anybody?
No.
No, that's not the
No.
idea. That's not the idea of you vaccinating. The idea of you vaccinating is that you want to induce a B cell or a T cell that is specific to that vaccine antigen, right? And
Yes.
and that will require you to have some naive B cell or T cell initially, so that you can now commit them to memory cells that can recognize that vaccine antigen. Do you understand what I'm saying?
Yes.
So, but
Yes.
if the naive T cells are not there initially, that means that if you are vaccinating, nothing will respond. So that is immunosenescence. So they cannot respond to new infection. They cannot respond to vaccination. That's why you don't waste time vaccinating somebody that is old, because you cannot achieve anything. But their memory cells are preserved. The musculoskeletal.
No, it's naive B and T cells, same as innate.
Same as what?
Innate immunity. Would they give
No.
naive?
So if we are talking about the B cells, the T cells, that is no longer
Mhm.
innate immunity. That is adaptive immunity.
That's so naive.
So when you're saying innate, we're talking about stuff like the skin, maybe complements, maybe macrophage,
Neutrophils.
neutrophils, all those things. But when you're talking about specific immunity, adaptive, you are talking about your B cells and your T cells. So those are adaptive immunity that they have to be developed against all infection in this world. If any infection is coming from this world, there will always be a B cell or a T cell that is specific to that infection. They must adapt to that infection. Do we get it?
Okay. So they lack the naive
They lack
B
the
and T
naive T cells. So the naive T
cells.
cells are like the what word can I use to? They are like the raw materials that will give the B cells and the T cells. They are the raw ones that they have not committed at all.
Okay.
So if
But
if COVID comes in, one of the naive B cells will develop into B cells that can recognize COVID. If HIV comes in, one of the naive B cells will now develop into B cells that can recognize HIV, and they will form memory cells and they will stay there. Do we understand? But if all the naive B cells have been depleted, can they recognize any new antigen again? No. So
you say when you say they preserve the memory B cell and T cell.
Yes.
Memory being.
Yes.
Can you elaborate more on that one?
So the memory B cells, they live longer. Let's just look at it that way. They live longer. So the effect of aging doesn't affect them. Because they are committed already, just stay there. Hello?
Yeah, I know. Yeah, that's why I know that B cells and T cells have memory B cell and innate. Okay, I'm still confusing it with the innate and the adaptive.
So if we are talking about adaptive, you only focus on B and T cells. Forget about the neutrophils and macrophage.
Those are the ones that have memory B cells. Memory cells, isn't it?
Yes. So the B cells and the T cells are the ones that have memory.
Uh-huh. So now, why are they losing it and then they're preserving it? I don't get it.
These naive B cells are the ones that will form the memory B cells.
Okay. Uh-huh.
And they
So
form
they
the B
leave
cells.
that original one.
Hello, please let's mute our mic. So these naive B cells are the ones that will form the memory B cells. If a new infection comes in, your naive B cell will differentiate into a memory B cell that can recognize that infection in the future.
Okay.
So now what I'm saying now is that with aging, these naive B cells are depleted. They are depleted. But all the memory B cells that the patient has formed from birth till that age will still be there.
Okay.
I'm just giving an analogy so that you understand what I'm saying.
Your analogy very, very well now. kind of cleared my confusion. Thank you.
Okay, so that's why they cannot respond to new antigens because they don't have
Yeah,
any naive B cell they give.
nice.
So you don't give
Yeah.
them vaccine, nothing will be provoked.
Mm.
So musculoskeletal, reduced skeletal muscle mass. Osteopenia, because of muscle requires protein. There's telomere shortening, there's epigenetic mutation. You cannot form DNA replication or protein synthesis. So the proteins will go down, skeletal muscle mass goes down. Same for the bone, it goes down. Then for the brain volume also reduces. The neurons start losing their function because they require high density of mitochondria. And also telomere shortening, they start dying gradually. The cerebral blood flow drops, but their function is still preserved a little unless they start developing dementia. So if there's no dementia, and the only problem is just reduction in brain volume from neural loss and reduction in blood flow. So if you do a mini mental state evaluation, so what score do we expect for normal aging?
Low,
Should be low.
This
less than
is
20.
I think shouldn't. I don't
Or
think it should be
not really
worse
that
than
low.
25.
Maybe mild.
it should be more than 24 over 30.
Okay.
It should be more than
Mm.
24. So once it is getting less than 24, then you can now start saying that, okay, maybe this person is having dementia. For normal aging, it should be more than 24. So that's what I want us to have at the back of our mind. For the special senses, impaired accommodation, presbyopia. Presbyopia is an aging complication of the eyes because the accommodation is reduced. The accommodation is like, okay, they cannot focus on a near image because if you want to focus on a near image, you need to contract and make the lens more convex. So because the elasticity of your ciliary muscle and everything is going down, they will not be able to stretch the fibers and contract the lens. So accommodation reduces. That's presbyopia. So they find it very difficult to see something that's even near, right? You can be near them and they will not be able to recognize you. So then hearing too reduces, presbycusis, and this is due to the generation of the hair cells in the hair. Hair cells is going down. They find it very difficult to smell and taste as well. Skin. So there's atrophy of the dermal epidermal junction. There's degeneration of the collagen and elastin. We already know that because of telomere shortening, epigenetic mutation, silences of expression of collagen and elastin. And from what we talked about in dermatology, we talked about senile purpura, in which you don't have enough collagen and elastin to support the skin vessels. They can easily rupture, right? And there's going to be bleed. That's why if you look at some old people, if you look at the back of their fingers, you see the senile purpura there, and you think that they fell or something. No, that's normal effect of aging, because you see this in an elderly person. This is normal, totally normal. So because the collagen that form a scaffold for the blood vessels here are lost, so the blood vessels become unsupported and they can easily rupture and bleed into the skin. So this is senile purpura. It's one of the effects of aging. We talked about it in dermatology. And because of the reduction in
Not to take you back before you go too far, I'm still pondering the cognition. The mini mental test, isn't it to assess cognition?
yeah, it is used to
Okay,
grade the impairment in cognition.
so
Right.
are you saying that it's intact in elderly except in Alzheimer? Is that what you're saying?
It can be impaired in elderly, but it will be mild. That is, it will still
Okay,
be greater than 24.
still greater than 24.
24, yes. It's going to be mild. So that's it. And they will still be able to do some function. They can still read
Yeah.
the paper. They can still talk to you, make meaningful conversation, right? Unlike someone that has dementia, that might be asking you like, what's the time? Where am I? Did I do that? Where did I put this? All those kind of things. But elderly people might still be able to, live by themselves. They can still function, with minimal support, because of all this reduction in blood volume, despite this reduction in this blood volume and reduction in cerebral blood flow. So that's what I'm saying. So because their cognitive issue is just mild, just still more than 24. Once it's less than 24, it's already entering into the range of dementia. So we can confirm that from our neurology. Dr. Brian did not talk about that in neurology. Okay. So sweat glands is also reduced. There's a reduction in sweat glands. And is somebody helping me confirm that from neurology? Please.
What do you want us to confirm?
Hello?
What do you want us to confirm?
The cognitive range.
Maybe he did. Maybe he did. Okay. It's just, I think it's just the little thing that you just said there about he did. It's just that I thought that in mini mental test that it would be less than 24, going down to 20, whatever. But I get it now that you said it, because it's the cognition is mildly decreased.
Yes, it is. It's just mild. Yes.
Okay.
So I think 24 out of 30 is still low. If a young person is still having 24 out of 20, that might still be low. So
yes,
that's it. So for the sweat gland, it's reduced too, and they can easily develop heat stroke because they find it very difficult to dissipate heat from their body. If there's no sweat gland, there's no way they can cool the skin and dissipate heat. The sebaceous gland too reduces, so they have xerosis cutis, in which their skin becomes very dry. And we talked about the aging phenomenon, the intrinsic aging, which is the chronological one. And that one is just due to the fact that collagen and elastin reduces from the fact that the fibroblasts can no longer deposit them and the skin starts wrinkling. That's normal chronologic aging. But there's another thing that we call the photoaging, which is extrinsic aging. So this one can even occur in someone that is 20-year-old, provided that the person is having a prolonged sun exposure. And we talked about the fact that sun has a large amount of UVA that can penetrate deep into the skin, degrade the dermal and the collagen and the elastin fibers, degrade them, and they will accumulate in the skin. And they will give that skin that abnormal wrinkling, pattern. So that's solar elastosis. So let me see if we have a picture, of what solar elastosis. So you see that premature wrinkling, of the skin, due to loss of the collagen and the elastin. So, and it also appears yellow. Sometimes it can appear red, yellowish, and the person might not even be that old. But if there's chronic sun exposure, and the person is having all this yellowish deposit in the skin with skin wrinkling, that's likely to be solar elastosis. I think we had a very good picture that we use in our dermatology. So that's just a part of physiology. It is due to the degraded collagen, and elastin accumulating within the skin. Then the renal system, what happens is renal filtration rate reduce. Why? Because the nephrons reduce in number. The renal blood flow also reduce. The hormonal function also drops because they can no longer produce erythropoietin and the other hormones, and they can even find it very difficult to pass urine, so they can have urinary incontinence due to neural reflex abnormality. Overflow incontinence, usually overflow incontinence. They can also have some reproductive issues. For in the males, they have the testicular atrophy, which is self-explanatory. The gonads, they are wearing out. Spermatogenesis drops. They can have BPH, because the risk factor for BPH is increasing age. That's the commonest risk factor. So if anybody wants to live long and the person is a man and the person doesn't want to have any issues, family size already completed, so many grandchildren, great grandchildren, you can just go and remove the prostate, and don't worry about that. Because if the prostate is not removed, there's a high chance of BPH happening or prostate cancer happening. So slower erection and ejaculation. So this one is just due to reduction in the level of the testosterone. So they have a very slow erection and slow ejaculation, and at the same time, the refractory period is prolonged. So that means that after an initial ejaculation, before the person can achieve another ejaculation, the time that it takes is very, very prolonged. So that's an influence of the reduced testosterone that they experience. So they also have a reduced, less pronounced reduction in the libido as compared to females. So their libido drive is not as like how do I put what's the word? Females tend to have a more reduced libido with aging than males. So that's why you see still like a 70-year-old man still giving birth, because of that. So it's not as if their libido disappears completely. It reduces, but not as severe as that of the females. So for females, because of the reduction in the estrogen from the ovaries, where now the follicles are exhausted, no estrogen again, vaginal atrophy, the vagina contracts and shortens, it becomes very thin, it's dry, and of course the flora there is disrupted. The lactobacillus that should be there creating acidic metabolites is killed off because of poor estrogen support, and of course the pH is going to increase at the end of the day. So that is due to the reduction in the estrogen from the ovarian follicles. So this one is something we can always reason out. The respiratory is important, very important. And we want to start by saying that the elastic recoil drops. So if we look at the lungs, the way it works is that so this is the alveoli, and it is surrounded by elastic fibers. And what those elastic fibers do is that they recoil. Now the recoil is inwards. They move inwards like this. They recoil inwards so that they can create a positive pressure to take out air at the end of expiration. So expiration is an active process, true or false?
False.
False.
So
Inspiration.
expiration is a passive process because what causes expiration is elastic recoil. Why inspiration is an active process because you need the contract diaphragm and other muscles to take in air. So that means that if somebody has a problem with elastic recoil, the person is going to have, issues with taking air out. Now, this is elastic recoil, first bringing the alveoli in this direction. So this one is coming like this one is coming like this, and they are pushing out the air. Compliance is the opposite. So if air is coming inwards like this into the alveoli must be able to stretch outwards in this direction and also in this direction. So that means that they are compliant, right? But if you have, just imagine that you have loss of these elastic fibers. So that means that we cannot squeeze the alveoli inwards again. But can we squeeze it outwards? Anybody? If it cannot move inward, which direction will it be moving?
Outward.
That is it. Because elastic recoil means you bringing it inward. So that means that the lungs will not be able to come inwards again with aging because they are losing their elastic fiber. So that means that they will be coming outwards. And if the lungs is coming outwards in this direction, are you going to say that they are compliant or not?
Yes.
Yeah.
Compliant. It is.
So don't make that mistake of thinking that compliance will reduce. In fact, the compliance is going to be increased. So same reason why compliance increase in COPD. Some people might find that very strange, but it's true. Someone that has emphysema, they have increased compliance because of this same problem. Because in emphysema, there's destruction of the elastic fibers. In aging, there's loss of the elastic fibers too. So compliance increases, but elastic recoil reduces. Now,
Okay, Baba, please can you take the elastic recall again with the
so
scenario?
elastic, just picture elastic recoil as inward squeezing of the alveoli. You are moving this force is coming like this, and another one is coming like this to squeeze the alveoli. What do you think will happen to the alveoli at the end of the day? It's going to collapse so that it can take out the air. Do you understand what elastic recoil means now? Now, compliance is the opposite. Compliance means that if air is entering, can it stretch to accommodate the air in opposite direction? Do you understand, Doc? Now, we are now saying that there's a loss of elastin fibers. It means that they cannot squeeze on themselves again. That means that it is going to be flabby and it can move outwards easily. So that means that compliance is going to be increased. For the chest wall, you're welcome. For the chest wall normally should be moving outwards. That's the normal thing for chest wall. That's the compliance. That's the elastic recoil for chest wall. They move outwards during inspiration to take in here. So that means that if they cannot move outwards, are they going to be compliant? No, because they cannot move outwards again. So they'll be stiff. And it will be very, very difficult for hair to come in. So the chest wall compliance reduces because of the loss of the elastic tendency. So because the normal elastic tendency for the chest wall is for them to move outwards during inspiration. The chest wall move outwards, so that you can create more volume for hair to come in. But when there's degeneration of those elastic fibers within the chest wall, there's no way they can move outwards again because they cannot stretch outwards. So the compliance is what? Reduced. And they become stiff. Can we picture all these things? Can we understand what I'm saying? I know it sounds a little bit abstract, but do we get what I'm saying?
Okay, Dr. Babawale, doesn't it contradict the increased compliance in elastic?
The direction of movement differs. I'm sure Dr. Babawale will have said this. The direction of movement differs. For the alveoli, they are moving inward so that you can take it out. You can take it out during expiration. But for the chest wall, where they exert their elastic recoil effect is during inspiration. You don't need chest wall compliance or anything in expiration. It is the elastic recoil of the lungs, the alveoli, that will do that. But during inspiration, you want to take in air, you need the chest wall to move outwards. And it's their elastic fibers that allow them to stretch outwards. If something is stretching outward because air is coming in, are we saying it's compliant or not?
It is compliant.
It is compliant. So if the elastic fibers is now gone, do you think it's going to move outwards?
No.
No. So it's going to remain where it is, stiff like that. So that means that it's what's it called? Its compliance drops. So you need to know the normal direction before you can understand the pathology. If you don't know the normal direction that they're supposed to move, there's a problem. So do you understand that? So the muscles of the respiratory tract too, because they require protein, they are going to start degenerating. So respiratory muscles weakens, the respiratory muscle strength drops. Now, to take in the functional expiratory volume is going to drop because they find it if the respiratory muscles are reduced, they find it very difficult to. Because don't forget, let me mention something. The first expiratory volume, the first vital capacity, both of them, they are going to drop. Let me tell you why. We have said that the expiratory muscle strength reduces, right? And don't forget, it is first we are talking about. So that means that you are recruiting some form of muscles. It's now becoming an active process. Do we get it? Do we know that first you are blowing? It's not tidal. I don't know if you understand what I'm saying. If you say first expiratory volume, it means the amount of volume of air that you can blow out from the lungs in 1 minute or in 5 FEV1 in 1 minute with the first breath. Do we get it? Like
Yes. Yes.
So if you think somebody that has someone that has reduced respiratory must be able to do no. So if the person cannot do that, what do you think will happen to the volume of air that will be, that can be breathed out? Is it going to be increased or small?
Small.
It's going to be
Reduce.
small.
Reduce.
So the forced respiratory volume is going to reduce. The forced vital capacity too will drop, because that one too is a function of how much air you can exhale after taking a what?
Normal breath.
Inspiration.
No.
Maximal.
After taking a what? After taking, someone said normal.
No,
Maximal.
After taking a maximal inspiration. So it's going to drop. Now, if somebody forced expiratory volume is reduced, now that means that the person find it very difficult to take out air from the lungs, right? What do we think will happen to the volume of air that remains in the lungs normally?
To increase.
To increase.
So that's why residual volume increases. Now, what is vital capacity for plus residual volume is what? This is respiratory coming back again. Vital capacity plus residual volume is what?
That's the expiratory.
Okay, let me start again. Inspiratory reserve volume plus expiratory reserve volume plus tidal volume is what?
Functional reserve.
40.
That's our vital capacity now.
Yes.
So vital capacity is what value? What is the value of vital capacity? Like the volume. What is the numerical figure? Anybody knows? Anybody knows? The numerical figure
Is
for
it
vital capacity.
500?
It's like
500
we
mil?
have forgotten this thing totally.
500 is the
500 mil?
It's not So is it 500 for what? No.
500 is the
It's too low. Tidal volume is 500. Tidal volume is 500. So functional vital capacity. Please, we have to know this figure, doctors. I'm not asking for too much, Please, I'm serious.
So you're not. It's
We
just
have to know that tidal volume is 500. You just do quietly. 500 has gone out and has come in. Tidal volume, right? Your vital capacity should be 4,800. Please, somebody should check it for us. Your vital capacity is 4,800. The amount of volume of air that remains in your lung after you have done a maximal exhalation, you have done it with all your mind. What will remain in your lung is your residual volume, and it is 1,002. If you add both of them together, what is it going to give you?
6 liters.
6 liters. Does 6 liters ring any bell? Does 6 liters account for anything? Does it ring any bell?
Yes.
What is 6 liters?
Yes.
That's the total lung.
That's the total lung capacity. That's the total. 6 liters.
Total lung
So the point is, functional vital capacity plus residual volume equals your total lung capacity. That's the total that your lung can take in, that can occupy in your total lung capacity is 6 liters. Now, they are telling us now that functional vital capacity is dropping and residual volume is increasing. So that means that there's a balance. Will our total lung capacity change?
Could you take that again, please?
No.
There is a drop in the functional vital capacity, forced vital capacity, and there's an increase in the residual volume. Both of them add up to make the total lung capacity. Do we going to have a change at the end of the day if both of them balances?
No, there will not.
Because the change that is happening here is going to be by the same amount. Your vital capacity is going to drop at the same amount as your residual volume is going to increase. So that means that if you add up these things, your total lung capacity is unchanged. This is the arrow question I'm giving us. Arrow question. So,
why will it be? Why will both of them, since vital capacity is has more volume than residual?
Okay. So
It's not like they're 50-50.
let me just quickly do it with an illustration. So the vital
Yeah.
capacity normally is 4,008, right?
Yes.
4,800.
Mm.
4,800. The residual volume is 1,002,
Okay.
right? Right?
Yes.
Now, force vital capacity drops by 800. It will drop to 400 to 4,000 due to aging, right? Now, because of this aging, we cannot take out the whole 4,000. I mean, how much volume of air do you think will be remaining in that lung?
800.
800. So
Yeah.
that means that there's going to be 800. So the normal volume of air that should be remaining in the lung is what? Residual volume, which is 1,002. Right, Doc?
Mm.
So that means that this 800 will be joining to this 1,002. Am I right?
Okay. Mm-hmm.
So it's
Mm-hmm.
going to be what? Residual volume is now going to be what? 2,000.
Mm-hmm.
Do you understand?
Mm-hmm.
So 2,000 plus
Yes.
4,000 is what?
Second 2,000 plus 2,000.
Yeah, 4,000 plus 2,000.
4,000.
Oh, it's 6,000.
It's still the
Okay.
6,000. So there is no
So
change.
nothing is lost. Okay.
Yeah.
I
So there's no
see.
change in the total lung
Wow.
volume. Very important stuff. So
Very.
what's going to happen to the air gradient? The reason why the air gradient is increased is because of what? With aging, the surface area of the alveolar reduces. So air gradient is going to. Hope we know the causes of normal air gradient. Hope we know.
Yes.
A.
High altitude
high altitude and
and hyperventilation.
IoT don't have ventilation. So I don't stress myself.
Hyperventilation.
What I used to remember it, anything that's going to compromise the respiratory organ, the respiratory system itself, will cause increase in air gradient. High altitude, there's nothing affecting my lung. The only problem is that I am, breathing from where there's low oxygen, high altitude. That's the problem. So that's why my air gradient is going to be normal. In hypoventilation, it's not actually affecting my lungs. It's just affecting maybe the chest wall or the muscles, right?
The
Person having
muscles.
myasthenia gravis,
Yes.
having obesity, all those things,
Obesity.
scoliosis, affecting the excursions of the muscles. That's the reason why the person could not breathe, not the lung. But if the person is having PE, the person is having pneumonia, having ARDS, there's a problem with the lung itself. So air gradient is going to be increased. Very fast way of palming it and you are moving. So if the air gradient is increased, it means that, and that is because the surface area of the alveoli has reduced, So that means that there's going to be ventilation perfusion mismatch. There could be ventilation perfusion mismatch. Why? But that one is actually due to reduced blood flow. So because with aging, you tend to have a reduced perfusion of of the lungs. So at the end of the day, you notice that the amount of air that is entering into the lungs is more than the amount of blood flow that is getting to the lungs. So there's going to be an increased ventilation perfusion mismatch. Please, we should scribble that somewhere. The blood flow decrease is more than the ventilatory defect. So even despite the fact that the air clearance is increased. So that's why the VQ mismatch is increased.
Can you repeat that? The blood flow decreases more than what?
The ventilation.
Okay.
Yeah. So ventilatory response to hypoxia or hypercapnia is blunted. Yeah. And they cannot be ventilating. They are hold. And they also exert less rigorous cough and slower mucociliary recurrence. So we are ending by talking about lipofuscin. Lipofuscin is just a normal wear and tear pigment with normal aging. It is composed of polymer of lipids and phospholipids, which are complex with protein. You just see them, they appear reddish or yellowish like this. So once you see something like this, after autopsy, just know that it is lipofuscin that they are trying to describe. Once you see it after autopsy, they did autopsy of somebody, and they are seeing complex of lipids and phospholipids, with protein. That is lipofuscin. And it's because all those lipids have undergone peroxidation. Don't forget, PUFA can undergo peroxidation from free radicals. With aging, definitely that person will have been susceptible to so many free radical insults. We have so many things that can generate free radical. Remember all these things: Fenton reaction, inflammation, radiation exposure, metal, and all those things. So that can cause the lipid peroxidation, and that thing will be complexing with protein, forming the lipofuscin. So they can deposit in older adults in the heart, colon, liver, name any other organs. But they will appear yellowish and brownish in color, just like this. So, on that note, we have come to the end of pathology. Do you have any question before we round it in?
Yes, I do. I have a question. In the AA gradient, is it good okay to say that anything that will not compromise the lung parenchyma, is that way? Is that the way you said it?
Yes. Anything that will not compromise the lung parenchyma.
Okay.
Anything that will not compromise the lung parenchyma will cause normal AA gradient.
Okay. Now, that being said, so it's not only high altitude and hyperventilation that will cause normal. You said obesity and what?
Obesity and myasthenia gravis are causes of hypoventilation.
Hypo, not normal.
Like, look at what you said, Doc. You said the things that will cause normal is what?
Hyperventilation and high altitude.